Okay, a very good morning to all of you. Now, if the audio and visual both are fine, just show me a thumbs up in the chat box. Good morning, all of you. Just show me a thumbs up. Audible? Great. Thank you so much. Okay. So 2 weeks left for your exam. I hope you are in proper spirits and अभी अच्छे से पढ़ाई चल रही है. All of you? Yes? Everything fine, I agree, but I hope you people are fine now. Tension हो रहा होगा, anxiety हो रही होगी, and so many of you would be thinking कि now I am going to quit, right? But this is not the time to quit. ठीक है? This is the time when you have to work harder and you have to prove yourself this time. So I am not going to waste your time. As far as OBS is concerned, OBS में whatever important questions I wanted to discuss with you, I have given it in the form of a PDF on my Telegram group. So many of you keep on asking me about the name of my Telegram group. So the name of my Telegram group, you have to search in capital letters. That is very important that you search in capital letters, and it is OBG. OBG by Sakshi Arora Hans. Right? There are 2-3 groups जो कि मैंने देखे हैं which are by my name, but I am available only in the group which has around 34,000 members, right? So that is the group where I am available. So there are so many other groups. Yesterday I was searching. There are 3-4 groups going on Telegram by my name. Some have 10,000 members, some have 12,000 members, but they are not my original groups. I am only in the group where you are going to get in capital letters OBG by Sakshi Arora Hans. So all the PDFs, all the important things which I want to share with you, they are available on that Telegram group. Go to the media, and media में जाके files में you can get all important images which I want you to revise, all important OBS के questions which I want you to revise, along with blank PDF and annotated PDF. And आज के session की भी जो blank PDF है, that is available on the Telegram group. Right? Okay. Is this available after live? Yes, it will be available, and I am not going to remove it. चलो, अब let us start with Gyne revision. अब Gyne में ना जो questions which they have started asking you are based on hormonal status. And this is not the time जब मैं बहुत सारे concepts build करा पाऊँ. Quickly हमें revise करना है. So I am going to give you tricks on how you are going to solve questions which are related to all the hormones, right? So some important concepts we will quickly revise. See whether it is a female or whether it is a male. So we have the hypothalamus. Hypothalamus में से GnRH is released in a pulsatile manner. So at puberty, GnRH release होता है from hypothalamus. This GnRH acts on anterior pituitary, and चाहे male हो चाहे female हो, LH and FSH are released from anterior pituitary, right? अब females में FSH जो है, it is going to act on ovary, and under the effect of FSH, 2 important hormones will be released, inhibin B and estrogen. कौन से cells release करेंगे? Granulosa cells. So granulosa cells से, again this is a very important question, कि granulosa cells से inhibin B निकलेगा and estrogen निकलेगा. This means कि अगर किसी female को granulosa cell tumor है ovary का, right? So this वो granulosa cell tumor of the ovary will also release estrogen. In other words, a granulosa cell tumor of the ovary is a feminizing tumor of the ovary. And if someone asks you what is the tumor marker for granulosa cell tumor, inhibin B, right? Clear to all of you? Now, under the effect of LH, what is going to happen? Number one, LH is responsible for LH surge, and is LH surge से, LH surge is responsible for ovulation. So for ovulation, LH surge is needed, and ovulation पे जितने भी important questions हैं, I have covered in OBS with you, but still I am telling you, they ask So when the levels of LH start increasing, that is the point which is called as LH surge. Right? So if someone asks you कि LH surge and ovulation के बीच में how much is the time interval, the best answer for this question is 32 to 36 hours. But if 32 to 36 hours is not given in the options, this is the best, then you are going to mark 24 to 36 hours. Number 1 point. So if someone asks you what is the time difference between LH surge and ovulation, answer is 32 to 36 hours. Second best answer 24 to 36 hours. अगर कोई पूछे what is the time difference between LH peak and ovulation, so do you understand when LH levels start increasing, that is what is the beginning of LH surge, and when they reach a height, the peak, that is LH peak. So LH peak and ovulation के बीच में time difference is 10 to 12 hours. If they ask you which hormone is responsible for LH surge, so estrogen is responsible for LH surge. So which hormone is responsible for LH surge? Estrogen. Please don't mind my handwriting. This is how it is. I can't change it now, but this is how my handwriting is. ठीक है? Now, so LH क्या करता है? LH is responsible, number 1, for ovulation, and number 2, LH acts on theca cells, and from theca cells androgens are produced. So in all females from puberty onwards, ovary is not only releasing estrogen but ovary is also releasing androgen. Right? So this is what happens in females. Now what happens in males? In males, FSH acts on Sertoli cells, and Sertoli cells say again what will be produced? Inhibin. And LH will act on Leydig cells, and Leydig cells say what is going to be produced? Testosterone. And this was your question which came in FMGE 2023. That testosterone is produced by which cells? Testosterone is produced by Leydig cells. Under the effect of which hormone? It is produced under the effect of Leydig cells, right? Under the effect of LH. Now, one more question which they ask you, कि ठीक है, LH is the one which is acting on Leydig cells to produce testosterone, right? एक question जो वो पूछते हैं, they ask you कि which is the first stimulus? Which is the first stimulus for, first stimulus for theca cells, just 1 second. First stimulus for Leydig cells to produce testosterone. What is happening? First stimulus for Leydig cells to produce testosterone. So what is the first stimulus? First stimulus ka answer is not LH. First stimulus ka answer is HCG. Again, this was a question which was asked in NEET 2023. Have you understood कि males में कैसे आ रहा है, females में how is the hypothalamic pituitary ovarian axis functioning, how is the hypothalamic pituitary testicular action functioning. Coming to next thing, estrogen always has a negative feedback on FSH. And estrogen usually has, ये word usually लिखा है, usually has a negative feedback on LH. Except, what is that except? Except is if estrogen is more than equal to 200 picograms for 48 hours, then it leads to LH surge. That means then it will increase LH. So normally estrogen decreases LH. And every time estrogen decreases FSH. Normally it decreases LH, but only in one condition estrogen will increase LH, that is जब estrogen के levels will be more than 200 picograms for 48 hours, then estrogen increases LH, and that is what is called as LH surge. I hope you will remember this, and that is why I told you which hormone is responsible for LH surge. It is estrogen which is responsible for LH surge. This was something which I told you just now. Have you all understood? Are you all understanding? Just show me a thumbs up if you are understanding. If you are understanding, I'm just waiting for a moment so that I can get your thumbs up to see whether you are understanding or not. Got it? Great. Abhinandan, thank you. And just tell me one more thing. तुम लोग को speed ज़्यादा तो नहीं लग रही है? I need to revise a lot more stuff with you. That is why I'm going a little fast. Okay, great. चलो. अब प्रोजेस्ट्रॉन क्या करता है? प्रोजेस्ट्रॉन हैज अ नेगेटिव फीडबैक ऑन LH एंड ऑन FSH. जब भी प्रोजेस्ट्रॉन इज इन हायर कॉन्सेंट्रेशंस, फर्स्ट स्टिमुलस बेटा HCG था. आई हैव मेड यू राइट. फर्स्ट स्टिमुलस वाज HCG. ठीक, चलो. जब भी प्रोजेस्ट्रॉन हाई कॉन्सेंट्रेशंस में होगा, इट विल हैव अ नेगेटिव फीडबैक ऑन LH एंड FSH. Testosterone always has a negative feedback on LH and FSH. Prolactin has a negative feedback on GnRH. Because prolactin has a negative feedback on GnRH, that is why जब भी prolactin के levels increased होंगे, whenever prolactin levels are increased, you will have decreased LH and decreased FSH. राइट? अब इस बेसिस के साथ वी आर गोइंग टू डू सम इंपॉर्टेंट कंडीशंस जिस पे क्वेश्चंस आते हैं. बट बिफोर आई टेल यू दैट, वन वेरी इंपॉर्टेंट कॉन्सेप्ट विच यू हैव टू रिमेंबर, ये जो GnRH होता है, इट इज, यू कैन मेक इट इन लैब्स ऑल्सो. सो वी आर मेकिंग सिंथेटिक GnRH. ये जो सिंथेटिक GnRH है, whenever you are giving synthetic GnRH in a pulsatile manner, जब भी आप GnRH को पल्सटाइल मैनर में देते हो, इट इंक्रीजेस LH, इट इंक्रीजेस FSH एंड इट इंक्रीजेस ईस्ट्रोजन. राइट? दैट इज व्हाई इट इज यूज्ड फॉर मैनेजमेंट ऑफ डिलेड प्यूबर्टी एंड इट इज यूज्ड इन मैनेजमेंट ऑफ कैल्मन सिंड्रोम. राइट? So, जब भी आप GnRH को पल्सटाइल मैनर में दोगे, इट विल इंक्रीज LH बिकॉज नॉर्मली भी बॉडी में GnRH इज रिलीज्ड इन अ पल्सटाइल मैनर, एंड जब भी GnRH को हम पल्सटाइल मैनर में देंगे, वो स्टिमुलेट करेगा पिट्यूटरी को. सो LH FSH बढ़ेगा, एंड वंस LH FSH increases, it increases estrogen. That is why in all those cases wherever you are getting delayed puberty, you have to give synthetic GnRH in a pulsatile manner. On the other hand, GnRH को जब हम continuous manner में देंगे, what it is going to do? When you are going to give GnRH in a continuous manner, it will decrease LH, it will decrease FSH and it will decrease estrogen. That is why in all those conditions, it will decrease estrogen. So that is why in all those conditions जहां पर estrogen के levels high होते हैं, so जितनी भी hyper estrogenic conditions होती हैं, in all hyper estrogenic conditions you are going to give GnRH in a continuous manner. For example, precocious puberty. For example, endometriosis. For example, fibroid. So, in सब में endometriosis is a hyperestrogenic condition. Fibroid is a hyperestrogenic condition. Precocious puberty का मतलब ये कि estrogen ज़्यादा था, इसीलिए जल्दी puberty हो गई. Now you will say कि मैम hirsutism में क्यों देंगे GnRH in a continuous manner? That is why I told you here कि LH जो है it acts on theca cells to produce androgens. तो जब भी फीमेल को हिर्सुटिज्म हो रहा है, दैट मीन्स उसकी बॉडी में एंड्रोजेंस ज्यादा है, एंड जब एंड्रोजन ज्यादा है तो हम क्या करेंगे? आई वॉन्ट टू डिक्रीज LH ताकि LH डिक्रीज हो एंड एंड्रोजेंस प्रोडक्शन डिक्रीजेस. दैट इज व्हाई इन हिर्सुटिज्म ऑल्सो यू आर गोइंग टू यूज continuous GnRH. Similarly, मेल्स में हम यूज करते हैं continuous GnRH for managing prostate cancer. In males में you can use continuous GnRH for managing prostate cancer. Continuous GnRH and synthetic pulsatile GnRH के uses you should be knowing. Clear to all of you? Yes. Chalo. Now go to the end of your PDF. In the end of your PDF, I have attached a table where we have written ki puberty, what is puberty and what is precocious puberty and what is a delayed puberty. All these definitions I have given you over here. If you go on, towards the last page 26 of your PDF. So page 26 of your PDF में I have told you some important points related to puberty. Puberty में you have to remember कि एक normal age क्या होती है puberty की females में 10.5 years. Males में 11.5 years. What is the sequence of puberty in females? Very, very important. The first sign of puberty in females is growth spurt. Right? Do not say breast budding. First sign is always growth spurt. उसके बाद जो first visible sign होता है, that is breast budding या thilarchy. Then pubic hair appear होते हैं, that is pubarchy. Then आता है peak height velocity and then menarche. So the sequence is growth spurt followed by breast budding, then that is called as thilarch, then pubarch, then peak height velocity and then menarche. So please be very careful over here. Puberty अगर 10.5 years पे start हो रही है तो menarche normally होती है 12.5 years पे. यानी कि there is a difference of 2 years between the onset of puberty and onset of menarche. Right? Males में अगर कोई पूछे what is the first sign of puberty? Testicular enlargement. केवल इतना जानना है. Right? Next you have to know कि for breast development in females, estrogen is needed. For pubic hair and axillary hair development, females maybe for pubic hair and axillary hair, you need androgens. Right? Now, what is precocious puberty? Precocious puberty is if puberty is happening at less than 8 years in a female or less than 9 years in males. Please remember, precocious puberty is more common in females. What is the most common cause of precocious puberty? Idiopathic. And क्या treatment होगा precocious puberty का? Continuous GnRH. Precocious puberty means that when puberty is happening at less than 8 years and उसके 2 साल के बाद menstruation होगा. So what is precocious menstruation? If menstruation happens at less than 10 years. Right? Delayed puberty का क्या मतलब है? Delayed puberty का मतलब है more than 13 years have passed. So 8 years precocious puberty, 13 years delayed puberty. बीच में 10.5 years normally puberty seen in females. Females का याद रखो, males नहीं पूछा जाता. Right? So if puberty doesn't happen by 13 years in females, that is delayed puberty. Delayed puberty is more common in males and the most common cause is constitutional delay. इसके अलावा there is one more reason for delayed puberty and that is Kallmann syndrome. What is the drug of choice? Just now I told you कि चाहे delayed puberty हो या Kallmann syndrome हो, what is the drug of choice? Pulsatile GnRH. Right? This session will be available even after I end the session. Even till 1 year after this, it will be available. I'm not going to remove it. Right? Chalo. This will be available. Don't worry, bachon. This session will be available. Don't worry at all. Now comes definitions for primary amenorrhea. Very, very important. Amenorrhea किसे कहते हैं? Primary amenorrhea की definition क्या है? And secondary amenorrhea क्या है? So, primary amenorrhea definition is if menstruation doesn't happen by 15 years of age. So, if menstruation is not happening by 15 years of age in a female with breast budding, So if menstruation is not happening by 15 years of age in a female with breast budding, or by 13 years of age in absence of breast budding, right? So breast budding nahi present hai by 13 years of age and tab menstruation nahi hua, and by 15 years of age tab nahi hua if breast budding is present. Second definition is, just now I told you कि puberty के signs and menstruation के बीच में normally there is a gap of 2 years, right? अब ये कह रहे हैं कि 3 years हो गए थिलार्की को. Thilarchy has happened 3 years back and your patient is not showing any signs of menstruation. So these two definitions for FMGE people I want all of you to remember. PPT is on my Telegram group. This is entirely present on my Telegram group, right? You can download it there from there immediately. So this is the definition for primary amenorrhea. दो definitions याद रखोगे. Absence of menstruation by 15 years if breast budding is present, or by 13 years if breast budding is not present. And number 2, absence of menstruation within 3 years of thilarchy. अब देखो question क्या आया था. This year it has come in NEET. Which of the following statements will you suspect primary amenorrhea? So option A था failure to attain menarche by 15 years. Yes. Failure to attain menarche even after 3 years of thilarchy? Yes. High levels of TSH and short stature? No. Failure of development of breast by 13 years. So obviously menstruation nahi hua and there is no development of breast by 13 years. Right? So the answer becomes A, B, C. 3 definitions I want you to remember. 15 years, breast budding present. 13 years, breast budding absent. Right? And 3 years have passed and the thilarchy was present. 3 years ke baad, after thilarchy, still you are not getting any menstruation. So failure of to attain menarche even after 3 years of thilarchy. Ye तीनों definitions you should be knowing. So A, B and D. Sorry, it's not A, B and C. It is A, B and D. Clear to all of you? Yes? Chalo. That is primary amenorrhea. Secondary amenorrhea, when there is absence of menstruation for 90 days. In other words, for 3 months in a female who was previously menstruating normally. Right? So 3 months ho gaye, she was earlier menstruating normally, but now 3 months have passed and she's not menstruating. Remember, if any female is having less than 9 cycles in a year, even she should be investigated for secondary amenorrhea. Clear to all of you? Yes. Now I want all of you to be very, very careful because question aayega where they are going to talk about LH, FSH and they are going to talk about various conditions and you will have to make the diagnosis. So suppose your question says that there is a female who's come to you with primary amenorrhea and she's complaining of cyclical pain in abdomen. जैसे ही आप ये पढ़ोगे cyclical pain in abdomen, right? It means and she is a case of primary amenorrhea. Primary amenorrhea है and cyclical pain in abdomen है. It means only one condition and that is cryptomenorrhea. Cryptomenorrhea. Cryptomenorrhea का क्या मतलब है? Hidden menstruation. And hidden menstruation का most common cause क्या होता है? Most common cause for hidden menstruation is imperforate hymen. Imperforate hymen. That's the most common cause for cryptomenorrhea. अब आगे क्वेश्चन में they can give you कि uterus present है. In a case of cryptomenorrhea, uterus present होगा. LH, FSH absolutely normal होंगे. Breast development absolutely normal होगा. Pubic hair and axillary hair absolutely normal. So the only problem is that there is the menstrual blood is unable to come out. Absolutely normal female hai, uterus normal hai, LH FSH levels normal hai, breast development normal hai, pubic hair normal hai, right? Please remember that cryptomenorrhea can be due to two causes. Most common is imperforate hymen, and a second cause is transverse vaginal septum. Transverse vaginal septum. Now understand, जब भी आपका क्वेश्चन कहेगा tensed bluish bulging hymen, it means they are talking about imperforate hymen, right? तो imperforate hymen भी cause होता है and transverse vaginal septum is also a cause. But also remember, suppose if your question is not saying anything, they are just saying, they are asking you the most common cause of cryptomenorrhea, then your answer is imperforate hymen, right? Always the most common cause is imperforate hymen, right? Now look at this question over here which came in your FMGE exams. A young girl who has not attained menarche complains of cyclical pain in abdomen. I told you, जैसे ही आप ये पढ़ोगे cyclical pain in abdomen, the first thing which has to come to your mind is cryptomenorrhea, and cryptomenorrhea का most common cause is imperforate hymen. Next question कह रहा है her breast development is normal. Just now I told you, in cryptomenorrhea breast development will be normal. Local examination of the genitalia showed the following image. So what you are seeing over here, tensed bulging hymen. It may or may not be blue in color. Blue in color तब मिलेगी जब blood बहुत लंबे time तक present होगा, right? So it may or may not be blue in color, and that means we are dealing with imperforate hymen. अब imperforate hymen का management क्या होता है? You have to give a cruciate incision on the hymen. You have to give a cruciate incision on the hymen. That is your management for imperforate hymen. Next very important question is types of hymen. Types of hymen में please see over here, this is how annular hymen या normally ऐसे ही hymen होता है. If you are not getting any opening, there is no opening. Normally hymen में एक opening दिखती है like this. So this is a normal hymen, right? अगर hymen में कोई opening नहीं दिख रही, that means imperforate hymen. अगर आप hymen में ऐसा appearance आ रहा है, that means कि यहाँ पे एक सेप्टा है, हाइमन के बीच में एक सेप्टा है. कैन यू सी, दिस इज अ सेप्टा इन बिटवीन द हाइमन. आई एम इरेजिंग सो दैट यू कैन सी इट प्रॉपर्ली. दिस इज कॉल्ड एज सेप्टेट हाइमन. अगर छन्नी की तरह सीव लाइक हाइमन मिलेगा, then it is cribriform hymen. So I want you to remember only three images: imperforate hymen की image, septate hymen की image, and sieve-like hymen, that is cribriform hymen's image. These three images are important for your upcoming exam. Clear to all of you? Yes? चलो. Now अभी हमने क्या पढ़ा था कि uterus was present. Uterus present था and breast was normal, pubic hair was normal, right? अब हम पढ़ रहे हैं कि your question is saying that there is primary amenorrhea, right? Uterus present है but breast absent है and pubic hair absent है. अब जब भी क्वेश्चन में ऐसा आएगा कि uterus is present but breast is absent and pubic hair is absent, you have to see कि क्वेश्चन में LH FSH की वैल्यूज क्या दी हैं. Have they given LH FSH decreased or have they given LH FSH increased? Right? Absent breast and pubic hair में there can be two conditions: LH FSH decreased, LH FSH increased. अगर क्वेश्चन कह रहा है LH FSH decreased, then there is only one diagnosis, and that one diagnosis is Kallmann syndrome. Kallmann syndrome. Calvin syndrome is something which is hypothalamic failure. हाइपोथैलेमस फेल कर जाता है एंड जीएनआरएच रिलीज नहीं होता. ऑब्वियसली जब जीएनआरएच रिलीज नहीं होगा तो एलएच भी कम होगा, एफएसएच भी कम होगा. दैट इज व्हाई आई एम टेलिंग यू, if your question is saying that case is primary amenorrhea, uterus present, LH FSH decreased, you only have to think about one answer and that is Kalman syndrome. Additionally क्या दिया होगा क्वेश्चन को थोड़ा सा कॉम्प्लिकेट बनाने के लिए एंड टू गिव यू सम हिंट्स, they are going to say that height of the patient is normal and patient has anosmia, inability to smell, right? And just now I told you Kalman syndrome mein there is only one management that you have to give, pulsatile GnRH. That is the management for Kalman syndrome. Pulsatile GnRH. ठीक है? Now comes second situation. Excellent beta. The gene which is involved in Kalman syndrome is Cal1 gene. But for FMGE, I'm sure they're not going to ask you the gene. ठीक है? It's good that you know Cal1 gene, but probably they might not ask this question. Now comes, see, FMG exam या जो भी ऐसा exam होता है in which you have just, which is a kind of clearing exam where you have to get 50%. They are going to test your clinical knowledge. They want to see कि आपने when you were doing your undergraduation, how much clinical knowledge have you obtained. They will never test you on theoretical knowledge. They will ask you questions which are related to clinical knowledge, right? Chalo. Now comes LH and FSH increased. अब अगर question कहता है कि primary amenorrhea with uterus present, absent breast and pubic hair and LH FSH increased. अब LH FSH increased है तो in the question C क्या short stature दिया है या normal stature दिया है. If the question is saying short stature, so अब क्या हुआ? Your question is saying primary amenorrhea, question is saying uterus present है, breast absent है, pubic hair absent है, LH FSH increased है, height is short. The moment they say LH FSH increased है, I know कि I have two things in my mind. Either this is a case of Turner's syndrome or this is a case of Swyer's syndrome. Only two differential diagnoses are there, right? तो अगर short stature है तो Turner's syndrome, normal height है तो Swyer's syndrome. ये दोनों किस चीज के एग्जाम्पल्स हैं? बोथ ऑफ देम आर एग्जाम्पल्स ऑफ गोनाडल dysgenesis. Both of them can come under the category of gonadal dysgenesis. एक में height short है, एक में height normal है. Height short है, it means we are dealing with Turner's syndrome. What is the karyotype in Turner's syndrome? It is 45XO, right? And in Turner's syndrome, gonads कैसे होते हैं? Gonads are streak ovaries. Please remember, streak ovaries should never be removed. So streak ovaries कभी malignant नहीं होती, so they should never be removed. And in addition to that, you will get features of Turner's syndrome. So pathology में you have read about features of Turner's syndrome, like short, the low posterior hairline, then webbing of neck, then shield-shaped chest, right? Sandal gap. Then so all these features किसमें मिलते हैं? All these features you get in Turner's syndrome. Low posterior hairline, webbing of neck, shield-shaped chest, right? Widely spaced nipples, cubitus valgus. All this we have studied in pathology. So additional features of Turner's syndrome भी हो सकते हैं. So I am repeating. Whenever your question says uterus present, breast absent, pubic hair absent, LH, FSH high and short stature. Diagnosis is Turner syndrome. Whenever they give you the same findings but they say normal stature, it means it is Swyer's syndrome. Right? Swyer's syndrome mein what is karyotype? It is 46XY. Please remember, whenever Y chromosome is present, Y chromosome के short arm of Y chromosome has SRY gene. Again, very, very important question. Y chromosome has, the short arm of Y chromosome has SRY gene. And whenever Y chromosome is present, gonads will always be testes, right? And ये जो testes होती हैं in Swyer's syndrome, they are undescended testes, right? And ये undescended testes, they present as bilateral inguinal hernia. They present as bilateral inguinal hernia. So one very, very important thing which you have to remember. आपके पास एक female आ रही है, right? You are getting a female who is complaining of primary amenorrhea, या केवल एक फीमेल है जो आपके पास bilateral inguinal hernia करके आ रही है. To all the budding surgeons, जब भी एक फीमेल bilateral inguinal hernia करके आए, आपके पास present करे, always ask her कि periods कैसे होते हैं, and she will say that there is primary amenorrhea. This means कि ये phenotypically appearance wise female है, but actually her karyotype is 46XY. Bilateral inguinal hernia का मतलब है कि they are undescended testes, and इसका मतलब है कि karyotype 46XY. तो जहां कहीं भी हमें क्वेश्चन में bilateral inguinal hernia दिखेगा, I know कि they are talking about 46XY karyotype, and that means ये bilateral inguinal hernia नहीं है, they are undescended testes. And जब भी undescended testes होती हैं, they always should be removed because there are increased chances of malignancy, right? तो bilateral inguinal hernia Swyer's syndrome में भी मिलता है and androgen insensitivity syndrome में भी मिलता है. Androgen insensitivity syndrome अभी आ रहा है, right? I will just now tell you कि how does a patient of androgen insensitivity syndrome present to you. But Swyer's syndrome का patient कैसे present करेगा? Swyer's syndrome में patient will have primary amenorrhea, uterus will be present, breast will be absent, pubic hair will be absent, and LH, FSH levels will be high. Height of the patient will be normal. Clear to all of you? So Swyer's syndrome के patient में these are the things you are going to get. Question में कहीं ना कहीं mention जरूर होगा that there is bilateral inguinal hernia, जो कि immediately हमें बता देगा we are dealing with 46XY karyotype. Clear to all of you? Yes? Okay. And always they should be removed because they have increased chances of malignancy. कौन सी malignancy? The most common malignancy is, the most common tumor is gonadoblastoma. Right? Okay. अभी तक हम उन प्राइमरी एमेनोरिया के केसेस के बारे में पढ़ रहे थे. तो सबसे पहले वी हैड स्टडीड प्राइमरी एमेनोरिया जिसमें यूट्रस प्रेजेंट था एंड ब्रेस्ट एंड प्यूबिक हेयर नॉर्मल थे. देन हमने पढ़ा प्राइमरी एमेनोरिया जिसमें यूट्रस प्रेजेंट है बट ब्रेस्ट एंड प्यूबिक हेयर एब्सेंट थे. नाउ वी आर गोइंग टू टॉक अबाउट प्राइमरी एमेनोरिया जिसमें यूट्रस एब्सेंट है. अब जब भी ऐसा क्वेश्चन आएगा, whenever you are going to get a question which says that there is primary amenorrhea with uterus absent, you have to just see कि breast and pubic hair कैसा दिया है. If they are saying both breast and pubic hair are well developed, very very important, दोनों breast and pubic hair are well developed, it means they are talking about Mullerian agenesis. Mullerian agenesis, जिसका दूसरा name is MRKH syndrome. This is 46XX. But if the same question comes that primary amenorrhea with uterus absent and they are saying breast is well developed but pubic hair is not well developed, then there is only one possibility, and that is androgen insensitivity syndrome. In androgen insensitivity syndrome, they are 46XY. Additionally, question हमें क्या बताएगा? Additionally, question हमें ये बताएगा that they are coming to you with bilateral inguinal hernia, right? They can also say a small blind vagina is present. Same thing they can say over here also, small blind vagina. यहाँ पे renal anomalies. Additional feature is renal anomalies. But diagnosis कैसे बनाएंगे? Diagnosis बनाने के लिए breast and pubic hair. Breast and pubic hair both are well developed in Mullerian agenesis. Breast is well developed and pubic hair is not well developed in androgen insensitivity syndrome. Please remember, इसको कहने का there is another way. They can say breast corresponds to Tanner stage 4 or 5. The moment they say breast corresponds to Tanner stage 4 or 5, इसका मतलब well developed. And pubic hair के लिए they can say Tanner stage 1 or 2. The moment they say Tanner stage 1 or 2, it means it is less developed, right? अब now you are saying, Rajika, we need to rule out Swires. बेटा, Swires में तो uterus present होता है ना? Swires में uterus is present. And ना तो breast होता है ना pubic hair होता है. Androgen insensitivity syndrome में uterus is absent. And breast well developed होगा and pubic hair will not be well developed. Have you understood? तो बहुत easy है दोनों में differentiate करना. Uterus absent है तो it has to be androgen insensitivity syndrome. Uterus present है तो it has to be Swires syndrome. So if your question is saying, I'll make it more simpler for you. If your question says bilateral inguinal hernia plus primary amenorrhea and question कहता है uterus present, it means it is Swires. Question कहता है uterus absent, it means it is androgen insensitivity syndrome. Clear? अब नहीं भूलोगे? Great. Now let us see in your questions, in your exams, what all questions have been asked, right? So, one is this question. Image देखते ही हमें समझ में आ गया that this image is of imperforate hymen. Question क्या कह रहा है? A 16-year-old female visits gyne OPD with complaint of cyclical pain in abdomen. जैसे ही cyclical pain in abdomen आया, I am thinking about imperforate hymen, right? Her general examination shows normal breast, normal pubic hair. Local examination shows bluish bulging hymen. Right? On per rectal examination, uterus is palpable. The most appropriate management. So you all know what is the most appropriate management. Excellent. Cruciate incision on the hymen. Chalo, next question dekhte hain. A mother, this is your FMGE June 2021. So a mother is bringing 18-year-old daughter to OPD who has not attained menarche. 18 years, not attained menarche. FSH normal, LH normal, right? Pubic hair are normal and breast development normal, right? Ultrasound shows absent uterus, blind vagina. अब हमें सोचना है एब्सेंट यूट्रस में मैम ने 2 कंडीशंस बताई थी, ईदर इट हैज टू बी मुलेरियन एजेनेसिस या एंड्रोजन इनसेंसिटिविटी सिंड्रोम। देन मैम ने हमें ये भी कहा था कि इन एंड्रोजन इनसेंसिटिविटी सिंड्रोम ब्रेस्ट तो वेल डेवलप्ड होंगे बट प्यूबिक हेयर विल नॉट बी वेल डेवलप्ड, जबकि इन मुलेरियन एजेनेसिस ब्रेस्ट विल बी वेल डेवलप्ड एंड प्यूबिक हेयर विल बी well developed. So probably this is Mullerian agenesis. आगे उन्होंने दे दिया karyotype 46XX. They have made the question so simple. It means this is Mullerian agenesis. जैसे ही इन्होंने दिया karyotype 46XX, it cannot be Turner's syndrome because it is 45XO. It cannot be androgen insensitivity because it is 46XY. It cannot be Swire's because it is 46XY. Right, so it has to be Mullerian, which is 46XX. Have you understood, all of you? And to confuse you all, हमेशा ऐसे FSH LH देंगे ही देंगे. अब एक चीज और याद रखना. In case of Mullerian agenesis, FSH and LH both are normal. FSH LH both are normal in Mullerian agenesis. Clear to all of you? Yes? चलो. Now coming to secondary amenorrhea. Similar manner में let us see that secondary amenorrhea में how questions are asked and how we are going to come to a diagnosis. So the most common cause of secondary amenorrhea is pregnancy. That's a question. That is why the first test which you should do whenever a patient comes to you with secondary amenorrhea is urine pregnancy test. Right? Okay. Now, in case of pregnancy, estrogen levels are high and progesterone levels are high. Because estrogen and progesterone levels are high, estrogen will have a negative feedback on FSH and mostly estrogen का नेगेटिव फीडबैक होता है FSH पे and mostly progesterone का नेगेटिव फीडबैक होता है on LH. Although both of them act on both of them, but generally estrogen is said to act on FSH to bring a negative feedback, right? And progesterone is said to act on LH to bring a negative feedback. So obviously estrogen and progesterone high हैं, तो LH and FSH both of them will be low in pregnancy. जब भी वो हमें प्रेगनेंसी बताएंगे तो दे आर गोइंग टू टेल अस कि यूरिन प्रेगनेंसी टेस्ट इज पॉजिटिव एंड दे आर आल्सो गोइंग टू गिव यू सम सिम्पटम्स ऑफ प्रेगनेंसी, राइट? So then I come to know, okay, I am dealing this secondary amenorrhea is because of pregnancy. Now a second cause of secondary amenorrhea is कि female has become menopausal at an early age. Right, that is what is called as premature menopause, and premature menopause का एक fancy name होता है, and this is the name which is being used these days, and that is primary ovarian insufficiency. Primary ovarian insufficiency, POI. POI is nothing, it simply means when menopause is happening at less than 40 years. So menopause at less than 40 years. So जब भी menopause happens less than 40 years में, that is premature menopause, and that is, it has got a fancy name which is called as primary ovarian insufficiency. अब primary ovarian insufficiency में या premature menopause में there are no more follicles in the ovary. तो no granulosa cells, no theca cells. No granulosa cells, no theca cells means no estrogen, no progesterone. And if no estrogen, no progesterone, what will happen? The negative feedback on LH and FSH will be gone. So LH and FSH will be high. तो जब भी ये premature menopause की बात होगी, in premature menopause, always the levels of FSH are high, right? And कितने high मिलते हैं? They are more than 45 international units. Clear to all of you? Yes, 40 to 45 international units के से ज़्यादा होता है levels of FSH. So you can write it as 40 to 45. Right? सो जब भी वो ये कहें सेकेंडरी एमेनोरिया विद एफएसएच लेवल्स हाई, एक ही कंडीशन होती है, सेकेंडरी एमेनोरिया विद इंक्रीज्ड एफएसएच is seen only in one condition, and that is premature menopause. Is this clear to all of you? The moment you get a question secondary amenorrhea with increased FSH, कुछ और नहीं सोचोगे, you are going to mark the answer as premature menopause. अब एक और condition होती है which can lead to secondary amenorrhea, and that is PCOS. PCOS में क्या होता है? In PCOS there is an ovulation. A female is not ovulating. Because a female is not ovulating, what happens to the levels of progesterone? They will be decreased. And because progesterone is decreased, the negative feedback on LH is gone. So LH levels are high. Estrogen is normal, FSH is normal. So in PCOS, FSH normal होता है but LH levels are high, right? Now, additional feature वो क्या देंगे? They will give additional feature as hirsutism. So in PCOS, FSH is normal, LH levels are high, right? That is why I told you FSH high है. It means it is menopause, right? FSH और किसी condition में high नहीं होता. PCOS में भी FSH नॉर्मल रहता है, LH हाई होता है. जो LH is to FSH रेशियो है वो PCOS में 2:1 या 3:1 हो जाता है, right? Then another condition which can lead another condition, so एक ही condition है जिसमें LH will be high and FSH will be normal, राइट? नॉर्मली या तो दोनों LH FSH हाई मिलते हैं या दोनों LH FSH लो मिलते हैं. PCOS की कंडीशन में FSH नॉर्मल मिलता है बट LH हाई मिलता है. क्लियर टू ऑल ऑफ यू? यस. नाउ then comes another condition which can lead to secondary amenorrhea, and that is prolactinoma. What is a prolactinoma? Prolactinoma is a prolactin secreting pituitary tumor, and just now I told you that whenever the levels of prolactin are high, it will decrease LH and decrease FSH. So FSH LH decreased है, it means it could be prolactinoma. अब could be prolactinoma का क्या मतलब है? बाकी चीजें क्या दी होंगी questions में that I am going to say I am dealing with a case of prolactinoma. Your question will say that patient is having secondary amenorrhea with headache, visual disturbances and galactorrhea. Headache क्यों हो रहा है? क्योंकि ये pituitary का ट्यूमर है, right? That is why headache हो रहा है. Pituitary के nearby structures are optic chiasma. That is why visual disturbances हो रहे हैं. And we all know that prolactin leads to galactorrhea. So if your question is saying there is secondary amenorrhea with headache, visual disturbances and galactorrhea, LH FSH levels are decreased, it means they are talking about prolactinoma. Remember, I am again repeating, there is only one condition जिसमें secondary amenorrhea होगा and LH and FSH both are high. That one condition is premature menopause. There is only one condition जिसमें secondary amenorrhea होगा, FSH normal होगा लेकिन LH high होगा, and that is PCOS. In a case of prolactinoma, you are going to get decreased LH, decreased FSH along with headache, visual disturbances and galactorrhea. Now, if they ask you what is the drug of choice for increased prolactin, what is the drug of choice for increased prolactin? Cabergoline. Do not say bromocriptine. The drug of choice is cabergoline. Now, another reason for secondary amenorrhea is Sheehan syndrome. What happens in Sheehan syndrome? There is necrosis of the anterior pituitary gland. So common sense tells me जब एंटीरियर पिट्यूटरी ग्लैंड है ही नहीं तो व्हाट विल हैपन टू LH एंड FSH? दे विल डिक्रीज, राइट. अब यू विल से कि मैम प्रोलैक्टिनोमा में भी LH FSH डिक्रीज था, यहां पे भी डिक्रीज है. हाउ एम आई गोइंग टू डिसाइड वेदर आई एम डीलिंग विद प्रोलैक्टिनोमा और शीहान सिंड्रोम? बेस्ड ऑन सिम्टम्स. प्रोलैक्टिनोमा की पेशेंट कंप्लेन करेगी हेडेक, विजुअल डिस्टर्बेंसेस एंड गैलेक्टोरिया की. शीहान सिंड्रोम की पेशेंट हिस्ट्री देगी कि शी हैड PPH and after delivery she was unable to lactate her baby. So if this history is present that there is PPH and there is failure to lactate the baby, then you are going to say that it is a case of Sheehan syndrome. Clear to all of you? Akshit, right, if I'm reading it correctly. Akshit beta, whenever a prolactinoma happens in pregnancy, you don't give any treatment unless and until visual disturbances are present. Prolactinoma is not treated during pregnancy. ठीक है? And the last condition could be Asherman syndrome. Asherman syndrome में there are intrauterine additions which are present or intrauterine synechia which are present. बाकी हाइपोथैलेमस नॉर्मल है, पिट्यूटरी नॉर्मल है, ओवरी नॉर्मल है, केवल यूट्रस में प्रॉब्लम है कि यूट्रस के अंदर एडिशंस प्रेजेंट है. दैट इज व्हाई LH इज नॉर्मल, FSH इज नॉर्मल, ईस्ट्रोजन इज नॉर्मल, राइट. So whenever LH, FSH and estrogen are normal and your patient has secondary amenorrhea, it is a case of Asherman syndrome. History में क्या मिलेगा? There will be history of postpartum curettage or history of excessive curettage. History of excessive curettage या postpartum curettage. Clear to all of you? Yes. Secondary amenorrhea में समझ में आ गया? So I'm quickly recapping it for you. Secondary amenorrhea के patient में अगर FSH increased है, LH increased है, it has to be premature menopause. LH increased है, FSH normal है, PCOS, right? LH decreased है, FSH decreased है, and patient is complaining of visual disturbances, headache, and galactoria, that is prolactinoma. LH decreased है, FSH decreased है, patient is saying she has history of PPH and she was unable to feed her baby. Sheehan syndrome. LH normal है, FSH normal है, and your question is saying कि patient has history of excessive DNCs being done, especially in the postpartum period. That means it is Asherman syndrome. Clear to all of you? Now look at the questions which were asked. Which of the following is not a cause of secondary amenorrhea? So tell which of the following is not a cause of secondary amenorrhea. A, B, C and D. इसमें both C and D are wrong. C भी नहीं है cause, D भी नहीं है cause. Both of them are incorrect and that is why this could be a wrong recall question also. या हो सकता है ये multiple choice question दिया हो. Which of the following is not a cause पूछा है बेटा. So it is both C and D. अब suppose यही question आया था. So in this case, what are you going to mark the answer? Better answer to mark is Turner's syndrome. But ideally, I believe कि ये options गलत दिए गए हैं and C and D both are not causes of secondary amenorrhea. Now, फिर आपके इसमें आया match the condition with appropriate hormone levels. तो tell me, Asherman syndrome में क्या मिलता है? LH, FSH, estrogen कैसा मिलता है Asherman syndrome में? Everything is normal. Sheehan syndrome में कैसा मिलता है? LH is decreased, FSH is decreased, and what happens to estrogen? So tell me what will happen अगर LH decreased है, FSH decreased है, what will happen to estrogen? Estrogen will also be decreased. PCOS में क्या मिलता है? PCOS में you get LH levels are high, FSH is normal या decreased and estrogen is normal या decreased, right? And okay, one second. This is here. Normal in this case, okay. Premature ovarian failure में क्या मिलेगा? Premature ovarian failure में LH and FSH both will be high and estrogen will be decreased. Right? So 1 का B, 2 का A, 4 का C, 3 का D. Right? अब यहाँ पे इन्होंने what they have given is कि PCOS के patient में they have said FSH and LH estrogen are decreased. Ideally FSH and estrogen are normal. But हम कैसे देख रहे हैं कि this is PCOS? Because they are saying LH is high. The moment they say केवल LH high, I know it is PCOS. When both LH and FSH are high, it has to be premature ovarian failure. Clear to all of you? Yes? Chalo. See, look at this question. A 25-year-old female attends Gyne OPD with secondary amenorrhea. She has history of previous DNC. The moment they say previous DNC, I am thinking about Asherman syndrome. Then they are saying FSH is 6 international units. Normally FSH कितना होता है? Normally FSH होता है between 1 to 10. It means FSH levels are normal. If FSH is 6, it means it is normal. So they are saying FSH is 6, that means FSH is normal. History of DNC and FSH normals. It means it is Asherman syndrome. Have you all understood how you're going to answer questions? Okay, all of you. Now coming to some syndromes in gynae, जिसमें we have to do PCOS first. Now, PCOS में there are 3 things. 3 important criterias in PCOS. Number 1, if a female is coming to you with complaints of hirsutism or if there are increased testosterone levels. Right? So, if a female complains of hirsutism or if there are increased testosterone levels. Right? Testosterone levels कितने हो? More than 70 but less than 200. Right? Number 2, female is coming to you with irregular cycles or oligomenorrhea or secondary amenorrhea. Plus ultrasound पे I am getting 12 or more follicles which are 2 to 9 millimeters in size in one or either of the ovary and volume of the ovary is more than equal to 10 cc. Right? So, I am telling you 3 things. Whenever your question says that there is a female who's come to you with hirsutism, number 1, or her androgen levels are high, and they are saying she is complaining of either irregular cycles or oligomenorrhea or secondary amenorrhea, and the question says that on ultrasound you are getting more than equal to 12 follicles 2 to 9 millimeters in size and the volume of the ovary is more than 10 cc. If any 2 of the above 3 are present, this is Rotterdam criteria. This is Rotterdam. Any 2 of the above 3 should be present. And this is what is Rotterdam criteria for diagnosis of PCOS. Right? So Rotterdam कहता है out of these 3, any 2 should be present. Please remember, generally, these follicles are arranged around the periphery of the ovary. Generally, the follicles are arranged around the periphery of the ovary. Generally, follicles are seen around periphery of the ovary, giving it a necklace appearance. Right? please remember that following features are seen in PCOS, but they are not a diagnostic criteria. Right? Diagnostic criteria are only these three, and from these three, any two should be present to say that the patient has PCOS. Right? And what are not a diagnostic criteria? ये features हैं. PCOS में generally females are obese. PCOS में you get insulin resistance. PCOS में LH is to FSH ratio becomes 2:1 or 3:1. PCOS में patients come to you with complaint of infertility, and this infertility is due to an ovulation. Right? But all these are features of PCOS. They are not a diagnostic criteria. Diagnostic criteria are only the three criteria which just now we have quickly revised. समझ में आया? Now, whenever a patient of PCOS comes to you, the first step in management of PCOS is weight reduction. Always. चाहे वो infertility के लिए आ रही है, चाहे वो hirsutism के लिए आ रही है, first step is weight reduction. Now, अब अगर आपका क्वेश्चन सिंपल सा एक क्वेश्चन पूछे, they are not telling you कि hirsutism की drug of choice, they are not telling you infertility, they are simply saying what is the drug of choice in PCOS. If you get a question like this, what is the drug of choice in PCOS, your answer has to be OCP. OCPs are the drug of choice in PCOS, right? Now comes specific question. They ask you what is the drug of choice for infertility in PCOS. Please remember, पहले drug of choice देने से पहले first step क्या करेंगे? Weight reduction. Before I tell her कि start with any drugs, I am going to advise her weight reduction. But the drug of choice is letrozole. What is the drug of choice? Letrozole. What is the second drug of choice? Clomiphene citrate. Both these are first line drugs. Drug of choice is letrozole. Second drug of choice is clomiphene citrate. सेकेंड लाइन में एक ड्रग आता है एंड एक प्रोसीजर आता है. ड्रग इज HMG. व्हाट इज HMG? ह्यूमन मेनोपॉजल गोनाडोट्रोपिन. ह्यूमन मेनोपॉजल गोनाडोट्रोपिन. एंड सेकेंड लाइन में एक प्रोसीजर आता है विच इज लैप्रोस्कोपिक ओवेरियन ड्रिलिंग. Laparoscopic ovarian drilling, सही से लिख दूं, otherwise I don't know what you guys are going to write. Drilling. Laparoscopic ovarian drilling. So first line drugs में we have first drug of choice as letrozole, second drug of choice as clomiphene. Second line में we have a drug that is HMG and a procedure that is laparoscopic ovarian drilling. So in your FMG, this question was asked, laparoscopic ovarian drilling is done for which condition? So laparoscopic ovarian drilling is done for which condition? Quickly tell me. It is done for PCOS. Is that clear to all of you? Yes. Laparoscopic ovarian drilling. Now, if they ask what is the most common complication of clomiphene citrate. What is the most common complication of clomiphene citrate? The most common complication of clomiphene citrate, jaldi se batao. Who's going to tell me? The most common complication of clomiphene citrate? I think there is a lot of lag in the video. So what is the most common complication? Is anyone going to tell me? It is not OHSS, Dr. Tanuja. No, bacha. No, Dr. Ripali. It is not OHSS. Excellent, Shah Faisal. It is hot flashes. Hot flashes. That is the most common complication of clomiphene citrate. जितने लोग OHSS बोल रहे हैं सब गलत है. OHSS most commonly किसके साथ मिलता है? Most common drug causing OHSS. What is the most common drug causing OHSS? It is HMG. Most common drug causing OHSS is HMG, right? Number 1. Number 2, if someone asks you what is the triggering factor for OHSS, triggering factor for OHSS is injection HCG. Triggering factor for OHSS is injection HCG. I was asking you what is the most common complication of clomiphene citrate? It is hot flashes. समझ में आया? Right? Now tell me, what is the drug of choice for irregular cycles? Drug of choice for irregular cycles is again OCP. फिर अगर वो पूछें what is the drug of choice for hirsutism? The drug of choice for hirsutism again is OCP. That is why I said कि अगर कोई हमसे पूछेगा drug of choice for PCOS in general, my answer is going to be OCP. Infertility के लिए it is letrozole or it is second drug of choice was clomiphene. अब हिर्सुटिज्म के पेशेंट में अगर OCPs फेल कर गए, so you have to give OCPs for 6 months, and if OCPs fail, then you have to give spironolactone. Then you have to give spironolactone. Please remember, spironolactone should never be given to a female if she wants to conceive. Right? So in that case, I will never be giving spironolactone. हिर्सुटिज्म के लिए लास्ट रिजॉर्ट क्या है? So अभी हमने जस्ट पढ़ा था कि if you are giving continuous GnRH, that can treat hirsutism. Right? So hirsutism का ट्रीटमेंट होता है, first drug of choice is OCPs. OCPs work नहीं करेंगे, I will then give spironolactone, and last resort is continuous GnRH. Now tell me a drug which leads to hirsutism. कौन सी ऐसी drug है जिसका side effect hirsutism होता है? The answer is danazole. Danazole. Right? So question कैसे आएगा? Question ऐसे आएगा, they are going to say all of the following drugs can be used for managing hirsutism except. उस except का answer is always going to be danazole. Why? Because danazole leads to hirsutism. That is why danazole can never be used to manage hirsutism. Is this clear to all of you? So a drug which can lead to hirsutism, someone has written minoxidil. Minoxidil doesn't lead to hirsutism. Minoxidil leads to hair growth. Hirsutism is not hair growth. Hirsutism is growth of hair in male pattern. That is around the lips, around the chin, right? Okay. Now, next. This was again one of your questions which was asked in FMG. जितने questions मैंने इसमें लगाए हैं, all of them are your previous year FMG questions, right? Which of the following is not used to treat PCOD or PCOS? So अभी हमने पढ़ा clomiphene citrate use होता है. Why? In case of infertility. Metformin use होगा PCOS में? Yes, because it is the drug of choice for insulin resistance. OCPs? Yes, it is the drug of choice for hirsutism. Hirsutism के केस में, irregular cycles के केस में. What is not used is tamoxifen. You don't use tamoxifen for management of hirsutism, for management of PCOS. अब एक question जो tamoxifen पे और आता है, and this was a question which was asked in your exams. Tamoxifen can lead to, if a female is using tamoxifen, what can it lead to? It can lead to endometrial cancer. Very, very important question. So, tamoxifen is one of the risk factors for endometrial cancer. Right? Have you understood? Now, look at these two ultrasounds. Both these ultrasounds are asked in your exams. Compare them. जो ultrasound A है, इसमें what are you seeing? In ultrasound A, you are seeing that there are follicles which are arranged around the periphery, and these follicles are small follicles. They are roughly 2 to 9 millimeters in size. right? And that is why this is an ultrasound of PCOS. On the other hand, जो हमें अल्ट्रासाउंड B दिख रहा है, इसमें I am seeing big follicles. Now, when you are seeing big follicles, it means this is OHSS. OHSS. As I told you, OHSS is because of, most commonly it is because of HMG. Have you understood? And triggering factor क्या होता है OHSS का? Triggering factor for OHSS is injection HCG. Clear to all of you? Yes, bacho? Okay. Now, look over here. This was a question which was asked in FMGE June 2022. A patient with breast cancer treatment with tamoxifen, she now presents with complaints of bleeding per vagina. What is the most likely cause? Tell me. Tamoxifen ka use leads to? So what does the use of tamoxifen lead to? Just now we did. It leads to endometrial cancer, right? So the answer over here is option A. Yes, perfect. Chalo. So I was doing syndromes with you, and सबसे पहला syndrome हमने पढ़ा PCOS. PCOS, what is the other name for PCOS? Steen-Leventhal syndrome, right? Now let us see the next syndrome which you need to know, and that is Asherman syndrome. Asherman syndrome में the problem is that there are intrauterine adhesions plus there is a defective endometrium, right? Now, Shah Faisal, beta OHSS में the management is that you have to, if it is a mild grade OHSS, then in that case you have to advise rest to your patient because उसको pain in abdomen हो रहा होगा, so you are going to give her some analgesics. Vomiting हो रही है तो उसको antiemetics दोगे. And अगर moderate to severe OHSS है तो उस patient को आप admit करोगे because severe OHSS में there are increased chances of DIC also, right? तो OHSS के patient अगर moderate to severe OHSS है, you are going to admit her, you are going to give her IV fluids, you are going to give her heparin so that उसको DIC ना हो, right? So I don't think so they are going to ask you management of OHSS. That should be reserved for NEET PG. ठीक है? Now, if they ask you what is the most common cause for Asherman syndrome, most common cause for Asherman syndrome is excessive curettage. Whenever you are doing excessive curettage, that can lead to Asherman syndrome. Highest risk is when you have done a postpartum curettage. If you have done curettage in the postpartum period. Tell me one infection which can cause Asherman syndrome. So Asherman syndrome can also be because of genital TB. Clear? Now, what is the most common symptom in Asherman syndrome? Please yaad rakhna. Most common symptom is infertility. Right? Infertility. Infertility अगर नहीं दिया है, then secondary amenorrhea, and वो भी नहीं दिया है, then hypomenorrhea. That means decreased bleeding. ठीक? What is the screening test for Asherman syndrome? Screening test for Asherman syndrome is HSG. What does HSG stand for? Hysterosalpingography. What is the investigation of choice in Asherman syndrome? It is hysteroscopy. Because hysteroscopy is diagnostic as well as therapeutic. आप जब hysteroscopy करोगे, साथ के साथ you are going to do adhesiolysis. You will cut the adhesions. So that is why hysteroscopy is the investigation of choice. It is diagnostic plus therapeutic. So you will do hysteroscopic adhesiolysis. Hysteroscopic adhesiolysis. Right? Okay. Then important points which you need to know on HSG. HSG पे बहुत सारे questions आते हैं. So some important points which you need to know on HSG. As I told you, in case of Asherman syndrome, the screening test is HSG. The investigation of choice is hysteroscopy. Asherman syndrome mein I told you FSH is normal, LH is normal, estrogen is normal. Right? चलो HSG पे कहाँ से क्वेश्चंस आते हैं? So number 1, HSG is investigation of choice for knowing whether the fallopian tubes are patent or not. Number 1. Number 2 क्वेश्चन आता है कि HSG कौन से डे पे करते हैं? It has to be done between day 7 to day 10 of the cycle. HSG is always done between day 7 to day 10 of the cycle. HSG is contraindicated in patients who have pregnancy. Obviously, हम dye नहीं डालेंगे in a patient who has pregnancy. Neither it has to be given to patients who have PID या genital TB, because अगर PID या genital TB है, जब आप dye डालोगे and when the dye is going to come out from the tubes, the infection will spread. So in infections also we are not going to do HSG. That means in PID and genital TB. The instrument which is used for doing HSG is a Leach-Wilkinson cannula. This name you have to know. Leach-Wilkinson. W hai. This is W. Leach-Wilkinson cannula. Right? Leach-Wilkinson cannula. This is how it looks. It will have a funnel-shaped tip with transverse serrations like this. So a funnel shaped tip with transverse serrations, and it will be like this. So whenever you are getting a funnel shaped tip cannula, it means it is a Leach-Wilkinson cannula, right? These were the important points on HSG. अब जब हम HSG करते हैं in case of Asherman syndrome, so basically HSG में करते क्या है? In HSG, so if this over here is the uterus, if this is the uterus, HSG में क्या करेंगे? In HSG, I will take a cannula and through this cannula, I will pass a radio opaque dye. I will pass a radio opaque dye and then I will see whether the dye is coming out or not. Right? That is what you do. And then I do X-rays to see whether the dye has come out or not. Right? This is what you do in HSG. You are passing a radio opaque dye and then you are doing X-rays and you are seeing whether the dye comes out or not. Now, in case of Asherman syndrome, जब आप HSG करोगे, when you are going to do HSG in Asherman syndrome, imagine, अंदर बहुत सारे additions हैं, right? There are additions. अब जहाँ कहीं भी addition होगा, वहाँ पे dye will not go. Right, so the dye is not going to go at those places where additions are present. That is why you are going to get multiple filling defects. These filling defects will be irregular and this will give a moth-eaten appearance. So in Asherman syndrome, in HSGs, you are going to get multiple filling defects which will be irregular and you are going to get a moth-eaten appearance. Now the dye, someone is asking me कि dye कौन सी use करते हैं? You use urographin. Urographin. This is a radio opaque iodinated dye. A radio opaque iodinated dye. Right? So this is the kind of appearance which you are going to get in Asherman syndrome. As you can see, I am getting multiple filling defects and these filling defects are irregular. So this is the picture which you are going to get in Asherman syndrome. And procedure क्या कर रहे हो? This procedure is HSG. Clear? Now, this was a question which was asked. अच्छा चलो उसके बिया. Now, in contrast to this, अगर fibroid होगा या polyp होगा, यूट्रस के अंदर, स्टिल हमें फिलिंग डिफेक्ट मिलेगा, बट दैट फिलिंग डिफेक्ट विल बी अ सिंगल फिलिंग डिफेक्ट एंड इट विल बी अ वेरी स्मूथ फिलिंग डिफेक्ट. So if there will be a fibroid or a polyp, then on HSG you are going to get a smooth filling defect, a single smooth filling defect, and that is the HSG of a fibroid or a polyp. Have you understood this? Yes. In your exams, these were the two questions which they had asked. Number one, they had asked, this instrument is used for. So you tell me, this instrument is used for hysterosalpingography. What is this instrument? This instrument is Leach-Wilkinson cannula. Right? Clear? Now, then they asked, identify the image. So obviously this is an HSG and what I am seeing is irregular filling defect. Now, because I am getting an irregular filling defect, it means that this is Asherman syndrome. Filling defect मिल रहा है तो it has to be either Asherman या fibroid या polyp. And smooth filling defect है तो it has to be fibroid. Irregular है तो it has to be fibroid या polyp if it is smooth. And if it is irregular, it has to be Asherman syndrome. Clear? This is not a normal HSG. Normal HSG में कभी भी filling defect नहीं दिखाई देगा. Clear? Now, please understand that जब भी हमें देखना है कि tubes patent हैं कि नहीं हैं, the investigation of choice is HSG. For tubal patency, the investigation of choice is HSG. But then it is not the gold standard. Gold standard is कि हमने, this is the abdomen, this is the uterus. Gold standard is कि नीचे से आप dye pass करो, right? So you pass a dye from below and ऊपर से एक laparoscope से देखो whether the dye is coming out or not. And this is what is called as laparoscopic chromoperturbation. Laparoscopic chromoperturbation, right? So the gold standard method for tubal patency ka investigation of choice is HSG and gold standard is laparoscopic chromoperturbation. Now they ask you, which is the dye which you are going to pass in this case? So the dye which is used for laparoscopic chromoperturbation, what is that dye? Who's going to tell me? Answer this question. This is your previous year question. A, B, C or D. A is saline, B is gentian violet, C is carbon dioxide and D is methylene blue. All of you are saying it is methylene blue. Everyone? I am not going to answer this question, Abhi, because I am just going to check and tell you. Because all of you are saying methylene blue, so I am going to first check and then I am going to tell you कि laparoscopic chromoperturbation में what is the dye? Yes, it is methylene blue dye. Yes? And if methylene blue is not available, then it is gentian violet. This was the confusion which I had. So gentian violet is not the answer of choice. The dye of choice is methylene blue. If methylene blue is not available, then we go for gentian violet. Right? So it has to be methylene blue dye. I will still confirm it because I don't know why I am getting this gentian violet always in my mind. So why is gentian violet coming to my mind? I don't know. one of them is first choice, the other one is second choice. It is methylene blue. Second choice is gentian violet. So the answer is, yes, I got anxiety for 1 minute that I am thinking it is gentian violet and these people are saying it is methylene blue. This happens. Chalo, theek hai. So it is methylene blue. Okay. Now coming to HSG images. Though or HSG images are important. One is where you are seeing that there is a blockage in the tube. Right, so there can be blockages at two places. Number one is when the dye, see this is Leach-Wilkinson cannula, dye has gone here, dye cornual end tak gayi and beyond the cornua the dye hasn't gone. Right, so this is an HSG with a bilateral cornual block. Now, whenever they give you this HSG and they ask you what is the most common cause of this, that the dye has gone only up till the proximal end of the tube. Normally dye should have gone inside the tubes also, but yahan pe I can see that the dye has gone only up till the proximal end of the tube. Beta, this is not uniconnovate uterus. Uniconnovate uterus mein you get a banana shaped uterus and one fallopian tube. Right, that is a uniconnovate uterus. Yahan pe hame kya dikh raha hai? Yahan pe I am seeing that the dye has gone inside the uterus, but dye angle of uterus ke aage nahi gayi. That means this is a case of bilateral cornual block. And if they ask you what is the most common cause of bilateral cornual block, it is physiological spasm. Right, most common pathological cause is genital TB. If they say that what is the next step always, जब भी हमें block मिलेगा, next step will be hysteroscopy and laparoscopy. क्या करोगे? Hysteroscopy and laparoscopy. Most of the times जब आप hysteroscopy and laparoscopy करोगे, तो जो भी ये spasm होगा, that is going to get relieved. If the spasm is not getting relieved and if the block persists, then the management is IVF. So these are all the questions which they ask you when they show you this HSG. Number one, this HSG is showing you bilateral cornual block. Number two, most common cause is physiological spasm. Number three, the most common pathological cause is genital TB. Number four, अगर ऐसा HSG मिल रहा है, what is the next step? Next step is hysteroscopy and laparoscopic chromoperturbation. So अंदर से भी डाल रहे हैं एक wire and ऊपर से we are seeing कि laparoscopy से the dye is coming out or not, and hysteroscopy के साथ साथ हम एक wire भी डालते हैं ताकि जो भी spasm हो that gets relieved. So hysteroscopy and laparoscopy, that is what is going to be in your options, that if there is a bilateral cornual block, what is the next step? Next step is hysteroscopy and laparoscopy. Right? Now, most of the times hysteroscopy and laparoscopy karne mein, the block is going to be relieved. If the block persists, you have to go for IVF. All questions done. Now, look at this over here. Look at this over here. This HSG. Now, what are you seeing in this HSG? In this HSG, I am seeing that through the Leach-Wilkinson cannula, dye has come inside the uterus. It is going in the tubes. But uske baad, I am seeing that the tubes are dilated. Right? And I am seeing that the dye is not coming out. That means this is a bilateral distal block. Right? And जब भी bilateral distal block होगा and they ask you what is the next step हमेशा यही रहेगा. Next step always is hysteroscopy and laparoscopy. So hysteroscopy and laparoscopy. And जब भी bilateral distal block severe होगा, management is IVF. Severe कब कहते हैं? जब इस तरीके की appearance मिले. This is hydrosalpinx. So जब भी ऐसी appearance मिले कि tubes are ballooned, tubes are inflated, swollen tubes हैं, that means hydrosalpinx and that means IVF. तो जब भी ऐसी image देंगे, management, best management is IVF. Next step is hysteroscopy and laparoscopy. This much you have to remember about the blocks, right? Now they ask you what is the epithelial lining of fallopian tube. So epithelial lining of fallopian tube is ciliated columnar epithelium, right? Next question. Which of the following will have false positive bar bodies? Now tell me, bar body क्या होता है? Bar body is number of X chromosomes minus 1, right? एक फीमेल में जब 46XX होता है नॉर्मल क्रोमोसोम नंबर, सो फीमेल्स में हाउ मेनी बार बॉडी? 1. एक नॉर्मल मेल्स में 0 बार बॉडी, राइट? दैट इज वन कॉन्सेप्ट. सेकेंड कॉन्सेप्ट इज कि जब Y क्रोमोसोम प्रेजेंट होता है देन वी से द जेंडर इज मेल, एंड जब Y क्रोमोसोम एब्सेंट होता है तब हम कहते हैं जेंडर फीमेल, राइट? सो नाउ दे आर सेइंग फॉल्स पॉजिटिव. फॉल्स पॉजिटिव का मतलब कि आइडियली इन अ मेल 0 बार बॉडी शुड बी प्रेजेंट. अब ऐसा मेल जिसमें 1 बार बॉडी इज प्रेजेंट, दैट इज अ फॉल्स पॉजिटिव. सो लेट अस सी ओवर हियर. टर्नर सिंड्रोम इज 45XO, 0 बार बॉडी. ट्राइसोमी 21. ट्राइसोमी 21 का मतलब है कि इफ दे आर 46 फीमेल है विथ ट्राइसोमी 41, सो इट विल बी 1 बार बॉडी, बट देन फीमेल है तभी 1 बार बॉडी मिल रही है. सो दिस इज नॉट फॉल्स पॉजिटिव, राइट? क्लाइनफेल्टर्स 47XXY. अब यहां पे देखो, क्लाइनफेल्टर्स में प्लीज अंडरस्टैंड Y क्रोमोसोम प्रेजेंट है. Y क्रोमोसोम प्रेजेंट मीन्स आई एम टेकिंग दिस एज अ केस ऑफ मेल, and because they have 47XXY, 2 X क्रोमोसोम्स हैं, तो बार बॉडी कितनी होगी? 1. आइडियली एक मेल में कोई बार बॉडी नहीं होनी चाहिए. यहां पे यू आर गेटिंग फॉल्स पॉजिटिव बार बॉडी. जैसे ही हम 1 बार बॉडी देखेंगे, आई विल से दिस इज अ फीमेल, बट एक्चुअली दे आर नॉट फीमेल्स, दे आर 47XXY. एंड जब Y क्रोमोसोम प्रेजेंट होता है दे आर मेल्स. प्लीज अंडरस्टैंड दिस वेरी वेल. हमेशा मेल एंड फीमेल इज डिसाइडेड बाय वेदर Y क्रोमोसोम इज प्रेजेंट और Y क्रोमोसोम इज एब्सेंट. Y क्रोमोसोम प्रेजेंट मेल, Y क्रोमोसोम एब्सेंट फीमेल, राइट? Bar body is not a very good method for sex determination. Why? I'll tell you this reason abhi. In a normal female, 1 bar body is present. In a normal male, 0 bar body is present. Clear to all of you, right? Ab imagine Klinefelter's syndrome. Klinefelter's syndrome is 47XXY. Y chromosome present hai, that is why I am saying they are males. लेकिन ये ऐसा मेल है जिसमें 1 बार बॉडी इज प्रेजेंट. आर यू अंडरस्टैंडिंग दिस? सो दिस इज फॉल्स पॉजिटिव. जब भी पॉजिटिव आ रहा है बार बॉडी, इट मीन्स इट शुड बी अ फीमेल, एंड जब भी नेगेटिव आ रहा है इट मीन्स इट शुड बी अ मेल, राइट? यहां पे पॉजिटिव आ रहा है, 1 बार बॉडी इज प्रेजेंट, पॉजिटिव आ रहा है, बट एक्चुअली दे आर मेल. सो दिस इज फॉल्स पॉजिटिव बार बॉडी. अब इमेजिन इन केस ऑफ टर्नर्स सिंड्रोम. टर्नर्स सिंड्रोम में देयर इज नो Y क्रोमोसोम. बिकॉज देयर इज नो Y क्रोमोसोम दे आर टेकन एज फीमेल्स. लेकिन बार बॉडी कितनी है? दे हैव 0 बार बॉडीज, यानी कि दिस इज फॉल्स नेगेटिव. आइडियली टर्नर्स सिंड्रोम आर फीमेल्स, सो एक बार बॉडी, 1 बार बॉडी शुड हैव बीन प्रेजेंट, but they are false negative. And Klinefelters are males, no bar body should have been present, but in them 1 bar body is present, that means they are false positive. Androgen insensitivity syndrome is 46XY, so 0 bar bodies, right? So false positive bar body किसमें मिल रही है? Klinefelter syndrome. अगर समझ में नहीं आया, so I just want you to remember, false positive bar body is seen in Klinefelters. False negative bar body is seen in Turners. Is that clear to all of you? Yes? समझ में आ गया? Okay. Now Klinefelters पे many questions are asked. So Klinefelter's के जो patients होते हैं, please remember a few things about Klinefelter syndrome. They ask you questions on Klinefelter syndrome in your FMGE exam. Klinefelter syndrome, they are 46XXY. They are males. They are males, right? They have a false positive bar body. They have tall stature. They have a tall stature. They have azoospermia. They will have azoospermia, right? They come to you with complaint of infertility. So they come to you with complaint of male infertility, and they can have gynecomastia. They may have gynecomastia. So 47XXY मेल्स होते हैं, फॉल्स पॉजिटिव बार बॉडी होती है, टॉल स्टेचर होता है इन मेल्स का, azoospermia होता है, they don't have sperms, and that is why they come to you with complaint of infertility. Some of them may have gynecomastia, right? Are you going to remember this much on Turner's syndrome, on Klinefelter's syndrome, all of you? Now look at this question. A couple came to you with complaint of infertility. On examination, her husband had gynecomastia and tall stature. What is the likely diagnosis? The likely diagnosis is Klinefelter's syndrome, right? Are you understanding? Turner's syndrome short stature होता है and ये females होती हैं, 45XO. स्वायर्स सिंड्रोम नॉर्मल स्टेचर होता है एंड ये भी फीमेल की तरह आती हैं, ये मेल्स की तरह नहीं प्रेजेंट करते हैं. टेस्टिकुलर फेमिनाइजिंग सिंड्रोम में भी नॉर्मल स्टेचर होता है एंड ये फीमेल्स होती हैं. सो इवन इफ यू डिडंट नो एनीथिंग अबाउट क्लाइनफेल्टर्स, you can eliminate and you can come to the answer, right? Please learn the technique of eliminating the options. हर चीज पढ़ाई नहीं जा सकती and हर चीज याद नहीं रखी जा सकती, right? More than teaching, it's more about your remembering. So try to eliminate the wrong options and you will come to the correct answer. We all know कि Turner's syndrome females की तरह present करते हैं, Swires syndrome primary amenorrhea females की तरह present करते हैं, testicular feminizing syndrome primary amenorrhea female की तरह present करते हैं, right? Now, match the following conditions with their respective karyotype. MRKH में क्या karyotype होता है? They are 46XX. Swires syndrome 46XY. Androgen insensitivity again 46XY. Turner's syndrome 45XO. Klinefelter's syndrome 47XXY. Clear? Chalo. Now, coming to infertility. So, females में infertility का one of the reason is anovulation and that is the most common reason. So, test for anovulation. So, test for anovulation में you have to check for serum progesterone levels on day 21 या day 22. This is the easiest and the best test. Best test to know whether a female is ovulating or not is serum progesterone levels, which you have to do on day 21 or day 22. Then you can also go for cervical mucus study, vaginal epithelial study, endometrial biopsy and basal body temperature and follicular monitoring. Follicular monitoring is done between day 7 to day, follicular monitoring is started from day 10 of the cycle on alternate days. On alternate days. बाकी जितने भी ये टेस्ट हैं, all of them are done on day 21 या day 22 of the cycle, right? All these tests are done on day 21 या day 22 of the cycle. Follicular monitoring has to be done from day 10 of the cycle on alternate days, right? अब follicles में बड़े सारे follicles होते हैं, right? So it can be a preantral follicle, antral follicle, then it can be a Graafian follicle. So if in the follicle you see a cavity, whenever in a follicle you are seeing a cavity present hai, तो it means it is antral cavity, and that means it is antral follicle. Whenever a cavity is seen, it means it is antral cavity and the follicle is antral follicle, right? Mature follicle को कहते हैं Graafian follicle. Mature follicle is called as Graafian follicle, and Graafian follicle is 18 to 20 millimeters in size just before ovulation. So one question is, antral follicle क्या होता है? Antral follicle is a follicle which has got antral cavity. So cavity अगर दिख रही है diagram में, it means it is antral follicle. Second question is कि Graafian follicle का what is the size just before ovulation? So the size just before ovulation is 18 to 20 millimeters, right? Then what is the drug of choice for an ovulation? Now अगर PCOS में question आता what is the drug of choice, then the answer was letrozole. But अगर question simply आ रहा है what is the drug of choice for an ovulation, they are not talking about PCOS, then the answer is clomiphene citrate. PCOS में answer is letrozole, otherwise the answer is clomiphene citrate. Please remember, which hormone is used as ovulation trigger? Is used as ovulation trigger. जब भी आप कोई भी ड्रग यूज कर रहे हो तो कौन सा हार्मोन इज यूज्ड एज ओव्यूलेशन ट्रिगर? आई एम राइटिंग ट्रिगर इन अ प्रॉपर मैनर सो दैट यू डोंट गेट कंफ्यूज्ड. ट्रिगर. So the hormone which brings about ovulation trigger is injection HCG, because injection HCG is similar to injection LH. HMG nahi beta. HMG is the one which brings about ovarian hyperstimulation syndrome, and ovarian hyperstimulation syndrome may be triggering factor always is HCG. जब भी ovulation trigger होना है या OHSS को trigger होना है, ओव्यूलेशन ट्रिगर पूछे तब भी इंजेक्शन HCG, OHSS में ट्रिगर पूछे तब भी इंजेक्शन HCG. ड्रग पूछे कि which leads to OHSS, it is injection HMG. But triggering point always is injection HCG. Clear to all of you? Yes. So tests for an ovulation में you have to remember the name of these tests. The best test is serum progesterone levels, right, जिसको हम day 21 या day 22 पे करते हैं of the cycle. The other tests are cervical mucus, then vaginal epithelial, endometrial biopsy, वो भी day 21, day 22 पे. Then follicular monitoring is done from day 10. Follicular monitoring में अगर आपको cavity दिख रही है follicle के अंदर, that means you are looking at antral follicle. Size of Graafian follicle just before ovulation is 18 to 20 millimeters. What is the drug of choice for an ovulation? Clomiphene citrate. What is the ovulation trigger? The ovulation trigger is injection HCG. Right? Now, then come what are the tests for ovarian reserve? What do you mean by tests for ovarian reserve? These are the tests which tell you whether follicles are present in the ovary or not. Whether follicles are present in the ovary or not, these are those tests. तो इन टेस्ट को करते हैं डे 3 पे, राइट? सो ओव्यूलेशन के लिए टेस्ट करते थे डे 21 या डे 22 पे. देन HSG करते थे ऑन डे 7 to day 10, and test for ovarian reserve are done on day 3. डे 3 पे इफ यू आर गेटिंग कि FSH लेवल्स हाई हैं, इनिबिन लेवल्स डिक्रीज्ड हैं, एंट्रल फॉलिकल काउंट डिक्रीज्ड है। देखो अगर फॉलिकल्स नहीं है ओवरी में तो दैट मीन्स ईस्ट्रोजन नहीं है, दैट ऑल्सो मीन्स इनिबिन नहीं है, बिकॉज बोथ ऑफ देम आर रिलीज्ड फ्रॉम ग्रैन्युलोसा सेल्स। एंड इनिबिन या ईस्ट्रोजन नहीं है तो द नेगेटिव फीडबैक ऑन FSH इज गॉन, सो FSH विल बी इंक्रीज्ड। दिस इज वेरी सिमिलर टू प्रीमेच्योर मेनोपॉज। फॉलिकल्स नहीं है इसका मतलब पेशेंट इज हैविंग प्रीमेच्योर मेनोपॉज, एंड आई टोल्ड यू जब भी FSH लेवल्स हाई हैं इट मींस प्रीमेच्योर मेनोपॉज। सो कभी भी हमने ओवेरियन रिजर्व के टेस्ट करने हैं तो हमें कौन कौन से टेस्ट करने हैं? हमें डे 3 पे FSH लेवल्स देखना है, डे 3 पे इनिबिन लेवल्स देखना है, एंड डे 3 पे TVS में देखना है कितने फॉलिकल्स मिल रहे हैं। दैट इज व्हाट इज कॉल्ड एज एंट्रल फॉलिकल काउंट, कि डू अ TVS एंड काउंट द नंबर ऑफ फॉलिकल्स. So obviously common sense tells me if there are no follicles, the number of follicles will be less, right? Because the number of follicles will be less, so there will be less estrogen, less inhibin, and so the levels of FSH will increase, right? And I will make a diagnosis of premature menopause. But all these tests have to be done on day 3. So that is why they are not the best test. Best test is anti-Mullerian hormone, AMH. Why is AMH the best test? Because it can be done on any day. And AMH is secreted from puberty onwards by the granulosa cells of the small antral and preantral follicles. तो जितने भी granulosa cells होते हैं puberty के बाद from the antral and preantral follicles they also secrete AMH. So in case of decreased ovarian reserve, AMH levels will be decreased, right? Normally AMH levels are between 1 to 3 या 1 to 3.5. If they become less than 1, then that means borderline. If it becomes less than 0.5, that means premature menopause या POI, right? So AMH is the best test for ovarian reserve. And the question which they had asked you, which of the following best measures ovarian reserve? So which of the following best measures ovarian reserve? Anti-Mullerian hormone. अब बताओ मुझे, suppose एक फीमेल है जिसमें फॉलिकल्स ही नहीं है, प्रीमेच्योर मेनोपॉज है, राइट? उसको अगर हमें प्रेग्नेंट बनाना है तो व्हाट कैन आई डू? इन दिस केस आई कैन यूज डोनर एग and I can do an IVF with the donor egg. That is the only way in which I can make her have her baby, right? So her husband's sperm and a donor egg, and then I do IVF. Clear to all of you? Yes? Then comes semen analysis. Now, before we talk about semen analysis, please remember, जब भी एक infertile couple आता है, in all infertile couples, for couples who are complaining of infertility, you have to do 3 basic investigations. 3 tests you have to do in them. What are those 3 tests? Number 1, you have to do serum progesterone levels on day 21 या day 22, because you will come to know whether the female is ovulating or not. Then you have to do HSG for tubal patency. I want to see कि उसकी tubes patent है कि नहीं है. And number 3, I have to do husband में semen analysis. These are the 3 basic investigations which you have to do whenever a couple is coming to you with infertility. These 3 things. Tubal patency, HSG कब करेंगे? Between day 7 to day 10. Right? Now, when should you start testing for infertility? When, if female is less than 35 years and there is 1 year of unprotected intercourse. After 1 year of unprotected intercourse. more than 35 years में after 6 months of unprotected intercourse. केवल ये याद रखो. Less than 35 years में after 1 year of unprotected intercourse, and more than 35 years में after 6 months of unprotected intercourse. Right? Now I want all of you, once the class is over, you are going to learn the new values of semen analysis. Right? All of you are going to remember this. Please remember, ये जितनी भी new values आई हैं उसमें total sperm count is the same and morphology का criteria नहीं बदला. These two criteria have not changed. Total sperm count is unchanged and the morphology criteria is unchanged. Right? Have you understood this much? Now, so total sperm count and morphology remains unchanged. What is aspermia? Absent semen. What is oligospermia? When sperm concentration is less than 15 million as per the older criteria and less than 16 million as per the new criteria. Right? Severe oligospermia का क्या मतलब होता है? Less than 5 million. So oligospermia means less than 16 million as per the new criteria, and severe oligospermia less than 5 million sperms per ml. Azoospermia, no sperms in semen. Teratospermia, abnormal sperm morphology. Asthenospermia, decreased sperm motility. Necrozoospermia, increased non-viable sperms. What is the most important parameter in semen analysis? Sperm morphology is the most important, followed by motility, followed by concentration. If on semen analysis you are getting azoospermia and they ask you what is the next step is repeat semen analysis after 1 month. And if still the report is saying azoospermia, then what is the next step? Then you have to do FSH. So if you are getting azoospermia and they ask you what is the next step is you have to repeat semen analysis after 1 month. After 1 month, again if you are getting semen analysis as azoospermia, it is still present, then you have to check FSH levels. Deliberately मैंने more than 40 years पे infertility का criteria नहीं बताया था because you will get confused. This is for NEET. For FMGE, just remember, less than 35 years में 1 year of unprotected intercourse, more than 35 years में 6 months of unprotected intercourse. More than 40 years में it is 3 months, but they will not ask you that. Right? Chalo. So this is what you have to remember on infertility. Now coming to some case diagnosis. So this is a question which came to you, that a patient has come to you with dysmenorrhea and dyspareunia. Please remember, जब भी आपके पास ये word आए dyspareunia, right, dysmenorrhea के साथ, every time the moment you get dysmenorrhea and dyspareunia together, it has to be endometriosis and nothing else. Dysmenorrhea and dyspareunia means that they are talking about endometriosis. Endometriosis में along with dysmenorrhea and dyspareunia you get infertility and adnexal mass. इन चारों में से कोई भी symptoms मिलेंगे, but dyspareunia और किसी कंडीशन में नहीं मिलता. डिस्मेनोरिया फाइब्रॉइड में भी मिल सकता है, डिस्मेनोरिया एडिनोमायोसिस में भी मिल सकता है. Dysmenorrhea and dyspareunia, only one condition, and that is endometriosis. Are you understanding this? Yes. Now, if they ask you what is the most common symptom in endometriosis, most common symptom is dysmenorrhea. And ये कैसा dysmenorrhea होता है? This is secondary dysmenorrhea. What are the per-vaginal findings? Very, very important in case of endometriosis. In case of endometriosis, ये दो terms मिलते हैं. Fixed retroverted uterus. कभी भी question में कहें fixed retroverted uterus, it means endometriosis, right? Adnexa में you will get bilateral adnexal mass. What is this bilateral adnexal mass? These are the chocolate cysts which you will feel. So on per vaginal examination, fixed retroverted uterus, and in the adnexa you will get bilateral adnexal masses. एक क्वेश्चन ये पूछते हैं that there is a female who is coming to you, suppose इसी में ये पूछें, and they ask you what is the next step, right? They ask you that a female has come to you with dysmenorrhea and dyspareunia. What is the next step? Please do not say that the next step is laparoscopy, although the investigation of choice is laparoscopy. बट नेक्स्ट स्टेप इज टीवीएस. खुद इमेजिन करो कि आप किसी डॉक्टर के पास गए हो विद कंप्लेन ऑफ डिसमेनोरिया, पेन ड्यूरिंग मेंस्ट्रुएशन, एंड डॉक्टर आपसे कहे कि मैं कल लैप्रोस्कोपी करूंगा. आर यू गोइंग टू बी सैटिस्फाइड विद सच अ डॉक्टर? नो. यू विल से पहले अल्ट्रासाउंड तो करा लो एंड देन get a laparoscopy done. Same thing. So whenever a patient comes to you with dysmenorrhea, even if in your mind you know that it is a case of endometriosis, the next step is never laparoscopy. Next step is TVS. On TVS, what you may see? You may see a chocolate cyst. Chocolate cyst को describe करते हैं as a cyst with homogeneous internal echoes. इसका डिस्क्रिप्शन ये होता है, ऑन अल्ट्रासाउंड ये लिख कर आएगा that a cyst with homogeneous internal echoes was seen, and that means it is chocolate cyst. The investigation of choice is laparoscopy. On laparoscopy you can get a gunshot appearance, you can get a powder burn appearance, you can get chocolate cyst, or you may see nodules. These nodules can be red in color if it is a fresh lesion, or new lesions may. Newer lesions will be red in color, old lesions will be bluish black in color. जितने भी new lesions हैं, they will be new and they will be red in color, old lesions will be black in color, right? So endometriosis में you have to remember, patient comes to you with dysmenorrhea and dyspareunia. They can be infertility, adnexal mass, right? On the first investigation always is TVS. On TVS you can see a chocolate cyst with internal homogeneous internal echoes. On per vaginal examination you are going to get a fixed retroverted uterus, and you may feel a bilateral adnexal mass, right? Now the question is, what is the best management to prevent recurrence in endometrial cysts? So recurrence को prevent करने के लिए best is cystectomy, and that is how you manage a chocolate cyst. Chocolate cyst, if it is more than 5 centimeters, it has to be managed by a laparoscopic cystectomy, right? What are the symptoms seen in endometriosis? Symptoms seen in endometriosis are dysmenorrhea and infertility. Please remember, menorrhagia is rare. तो कभी भी हम rare symptoms नहीं बताते हैं. Menorrhagia is not that common in endometriosis. So what are the symptoms? Dysmenorrhea and unexplained infertility. So answer becomes option D, that is 2 and 4. Right? मेनोरेजिया कम मिलता है बच्चों. मेनोरेजिया क्यों? वाई? क्योंकि ये जो एंडोमेट्रियोटिक इम्प्लांट्स हैं, वेयर आर दे प्रेजेंट? दे आर प्रेजेंट आउटसाइड द यूट्रस, एंड बिकॉज दे आर प्रेजेंट आउटसाइड द यूट्रस, दैट इज वाई यू डोंट गेट menorrhagia so common. What is common symptoms which you are getting here? Dysmenorrhea and unexplained infertility. So over here the answer should be 2 and 4. Clear to all of you? Yes. Now ये तो होता है endometriosis में जो endometrium है, that is present outside the uterus. Endometrium is present outside the uterus. Most common site is ovary. Second most common site is pouch of Douglas, right? Now if endometrium is present inside the myometrium, what is that called as? Adenomyosis. That is called as adenomyosis. Adenomyosis is more common in multiparous females who are more than 40 years. Adenomyosis में, because endometrium is present inside the myometrium, yes, you are going to get menorrhagia and you are going to get dysmenorrhea. तो जब dysmenorrhea के साथ menorrhagia होता है, I am not thinking about endometriosis. Endometriosis में patients do not come to you with menorrhagia. Endometriosis में pain के साथ आएंगे, menorrhagia नहीं होता. अगर menorrhagia and dysmenorrhea है, that means the diagnosis is adenomyosis and not endometriosis. Are you all understanding, bacha? Yes? Okay. So on per vaginal examination, in adenomyosis, uterus is symmetrically enlarged. Very, very important. Right? It is never more than 12 to 14 weeks pregnant uterus size. So it will always be less than 12 to 14 weeks pregnant uterus size. It will be symmetrically enlarged, and इस symmetrically enlarged uterus को globular uterus भी कहते हैं. Right? And uterus will be tender to touch. Uterus में tenderness present होगी. Right? So this is what is very, very important, that in case of adenomyosis, uterus tender होता है. Right? So in your questions it was asked, dysmenorrhea with tender uterus is found in. So dysmenorrhea with tender uterus is found in adenomyosis. Are you understanding? अगर ये कहते dysmenorrhea with fixed retroverted uterus, then my answer would have been endometriosis. Clear to all of you? Yes. So tender uterus is seen only in one condition, and that is adenomyosis. Fibroid में भी uterus is not tender. किसी और condition में uterus is not tender, only in adenomyosis uterus is tender. Another very important thing is, in adenomyosis uterus is enlarged. Definitely uterus is enlarged, but sorry, कितना enlarged? It is less than 12 to 14 weeks pregnant uterus size. इससे कम होगा, इससे ज़्यादा कभी नहीं होगा. Is that clear to all of you? Yes? Okay. What is the investigation of choice in adenomyosis? Investigation of choice is MRI. But it is not the first investigation. First investigation is TVS. What is the management? Management is total abdominal hysterectomy. Clear? Right? Now coming to fibroid. Fibroid की patient की main complaint होती है menorrhagia. Only menorrhagia. Right? Generally, there is no pain. Menorrhagia is the main complaint. Bleeding is the main complaint. उनको pain से pain नहीं हो रहा होता. Adenomyosis में pain and bleeding. Right? And endometriosis में only pain. Is that clear? On per vaginal examination, in case of fibroid, you get enlarged uterus, which is more than 12 to 14 weeks pregnant uterus size. बड़ा enlarged uterus मिलेगा. Irregular uterus मिलेगा. Right? क्योंकि fibroid कहीं से भी arise हो सकता है, तो irregular होगा uterus. And it is not tender. Right? Please understand that a fibroid can be of three types. Number one, it can be intramural fibroid. Intramural fibroid का क्या मतलब है? A fibroid which is inside the myometrium, right? Then it can be submucous fibroid. Submucous का मतलब है it is coming inside the uterine cavity, or it can be a subserous fibroid, right? So intramural, submucous and subserous. A fibroid which is growing towards the peritoneal cavity, subserous. A fibroid which is coming inside the peritoneal cavity, inside the uterine cavity, submucous. And a fibroid which is inside the myometrium only is intramural fibroid, right? Now, please understand that submucous fibroid में this also is intramural. This is a typical intramural fibroid. Right? अब question आया था, identify the fibroid marked with X. So the fibroid which is marked with X is towards the uterine cavity. So it has to be a submucosal fibroid. Right? Okay. Now, coming to submucous fibroids. Submucous fibroids, they can be type 0, type 1 and type 2. ये वाला जो fibroid है ना, ये वाला fibroid is a mixture of intramural and subserous. तो इसको typical intramural नहीं कहेंगे. This is intramural plus subserous. So FIGO ने gradings दी हैं. You don't need to know that. Typical intramural fibroid is this fibroid. This fibroid is a typical intramural fibroid. This is a subserous fibroid, a submucous fibroid. This is a subserous fibroid. As I told you, FIGO ने gradings दी हैं, जिसमें I just want you to remember कि सब म्यूकस की 3 ग्रेड्स होते हैं, टाइप 0, टाइप 1 एंड टाइप 2. ओनली व्हाट यू हैव टू रिमेंबर इज, व्हाई वी वांट यू टू रिमेंबर दिस इज क्योंकि टाइप 0 एंड टाइप 1 फाइब्रॉइड का मैनेजमेंट इज हिस्ट्रोस्कोपिक मायोमेक्टमी, टाइप 2 का अब्डोमिनल मायोमेक्टमी. सो आई जस्ट वांट यू टू रिमेंबर कि FIGO ने बहुत सारी ग्रेडिंग्स एंड टाइप्स बताए हैं फाइब्रॉइड के, बिकॉज ओवरलैपिंग होते हैं. जैसे ओवर हियर यू कैन सी ओवरलैपिंग है, ये इंट्राम्यूरल भी है एंड ये सबसीरस भी है. ये इनसाइड द मायोमेट्रियम है एंड इट इज ग्रोइंग टुवर्ड्स द पेरिटोनियल कैविटी ऑल्सो. सो इट इज अ मिक्सचर ऑफ इंट्राम्यूरल एंड सबसीरस फाइब्रॉइड. तो बिकॉज फाइब्रॉइड जरूरी नहीं है कि एक ही टाइप का हो, सो बहुत सारी ग्रेडिंग्स दी हुई हैं फाइब्रॉइड की, टाइप्स ऑफ फाइब्रॉइड बताए हैं. सो यू हैव टू रिमेंबर सब म्यूकस फाइब्रॉइड्स कैन बी डिवाइडेड इनटू 3 टाइप्स, टाइप 0, टाइप 1 एंड टाइप 2. टाइप 0 एंड टाइप 1 का मैनेजमेंट इज हिस्ट्रोस्कोपिक मायोमेक्टमी, टाइप 2 का मैनेजमेंट इज अब्डोमिनल मायोमेक्टमी. राइट? Is that clear to all of you? Yes. The other thing which you have to remember is a fibroid may become calcified like this. This is called as popcorn calcification. This is called as popcorn calcification. And this popcorn calcification means it is a calcified fibroid. It's a calcified fibroid. Right? So in fibroid, few things are, these are the few things which you have to remember. The other thing which you have to remember about fibroid is red degeneration of fibroid. Red degeneration of fibroid is more common in second half of pregnancy. Right? And patient will complain of, patient complains of pain in abdomen plus nausea, vomiting. Right? So patient will complain of pain in abdomen, nausea and vomiting. Pregnant patient hai with a fibroid and all of a sudden she has pain in abdomen and nausea, vomiting in second half of pregnancy. How do you manage it? You manage it conservatively. Management is conservative management. Please don't say that I will do myomectomy. No myomectomy for this patient. No termination of pregnancy for this patient. You are not going to say I will end her pregnancy. You are not going to end her pregnancy. You will continue her pregnancy and you will manage it conservatively with analgesics and antiemetics. Just give her analgesic and antiemetic. Her pain and nausea, vomiting will be taken care of. No myomectomy, no termination of pregnancy. Right? In case of red degeneration of fibroid, जब आप lab investigation कराओगे, you will see ESR is raised, WBC count is raised, and patient may have fever. But remember, this is an aseptic condition. It is an aseptic condition. Patient को fever हो सकता है, ESR भी बड़ा हो सकता है, WBC can also be increased, but still it is an aseptic condition. right? In spite of these things, you have to say that this is an aseptic condition. Is that clear to all of you? Red degeneration of fibroid is very important. Now, I want all of you to look at this Doppler ultrasound. Isme what you are seeing here is a polyp, and you are seeing that a single blood vessel is coming up till the center of the polyp. So I'm just showing you again. You have to focus on this single blood vessel which is coming up till the center of the polyp. So remember, polyp may, in case of polyp, so this is what is called as feeder vessel sign. Feeder vessel sign. In a feeder vessel sign, you will get a polyp, and polyp में एक single blood vessel आएगी which will go up till the center of the polyp. On the other hand, if this would have been a fibroid, फाइब्रॉइड के केस में क्या होता है? अ फाइब्रॉइड इज सराउंडेड बाय स्यूडो कैप्सूल, एंड जो ब्लड वेसल्स होते हैं दे आर प्रेजेंट इन द स्यूडो कैप्सूल, राइट? सो ब्लड वेसल्स आर प्रेजेंट इन स्यूडो कैप्सूल. Blood, this you can't see, I'm writing it here with another color. Blood vessels in periphery, in pseudo capsule. जबकि पॉलिप में एक सिंगल ब्लड वेसल आता है which is in going up till the center. This is what is feeder vessel sign. If you get this and they ask you what is the diagnosis is a polyp. So in case of polyps, patient will always complain of irregular bleeding. अगर क्वेश्चन में आए irregular bleeding या intermenstrual bleeding, please do not say fibroid. Fibroid के केस में the complaint is menorrhagia. That means excessive bleeding which will be regular. Normally जो period होता है वो heavy होगा, right? The patient will never say irregular bleeding. Patient will say कि whenever I have my periods, they are very heavy, right? But in case of polyp, patient will say irregular bleeding or there is intermenstrual bleeding. So whenever your question says irregular bleeding or intermenstrual bleeding, it means it is a polyp. Investigation of choice in polyp is hysteroscopy, right? And management is hysteroscopic polypectomy. Hysteroscopic polypectomy. But जब आप अल्ट्रासाउंड करते हो क्या दिखता है? On ultrasound, if you switch on the Doppler, you will get a feeder vessel sign, a single blood vessel going up till the center of the polyp, right? Now, these are gross images of fibroid. As you can see, fibroid is white in color. It has got a very rough surface, right? It has a whorled appearance. That is a fibroid. On the other hand, a polyp is a red fleshy mass. So, if you are seeing a small red fleshy mass, that's a polyp. Now, this over here is a symmetrically enlarged globular uterus, and that is adenomyosis. And जब हमने इसको cut किया, I am seeing that multiple hemorrhages are present in myometrium. These multiple hemorrhages का क्या मतलब है? Endometrium was present in myometrium, and ये endometrium menstruation के time पे bleed करी, and that is why I am getting multiple red spots inside the myometrium, right? So this is a adenomyosis. Coming to vaginitis, many questions are asked on vaginitis in your papers. I hope all of you are understanding this. Yes? All of you? Just show me a thumbs up if you are understanding. Okay. Now, vaginitis में The first thing is physiological discharge. Now, physiological discharge, how am I going to know that the discharge is physiological? Your question is going to say that there is a color. Okay, I've understood that you are understanding. So, the question is going to say that there is a colorless discharge, there is no itching and it is odorless. ये तीनों चीजें अगर दी हैं, colorless, no itching and odorless, then it means it is physiological discharge. So physiological discharge is colorless, no itching and it is odorless. Same चीजें अगर दी कि it is colorless, no itching, but they are saying that there is fishy odor or foul smelling odor. Odorless था तो physiological था. Odor के साथ अगर present है तो that means it is bacterial vaginosis, right? So colorless discharge या whitish discharge which is not causing any itching and it is odorless is physiological. But same kind of discharge, if it has odor, it means a foul smelling odor, it means it is bacterial vaginosis. In bacterial vaginosis, they are going to say that when a microscopic examination was done, clue cells are present. Clue cells are present. The moment you read this word clue cells, एक तो फाउल स्मेलिंग ओडर पढ़ो एंड इफ अगर क्लू सेल्स देखो, क्लू सेल्स का मतलब है अगेन दे आर टॉकिंग अबाउट बैक्टीरियल वैजिनोसिस. Clue cells are epithelial cells. They are vaginal epithelial cells to which bacteria are adhered. What are clue cells? They are vaginal epithelial cells to which bacteria are adhered like this. So यहाँ पे देखो ऐसी appearance आ रही है, right? So this is what is clue cell. The moment they give you this image, it means they are talking about bacterial vaginosis. What is the drug of choice for bacterial vaginosis? Metronidazole, right? It is not an STD. So no partner treatment. The criteria for diagnosis of bacterial vaginosis is Amsel's criteria. And whiff test is positive in case of bacterial vaginosis. ये कुछ चीजें मिलेंगी, but diagnosis में ये केवल ये देंगे that you have female is having a grayish discharge or white color discharge which did not cause any itching and it was foul smelling and clue cells were present, right? It means that it is bacterial vaginosis. Drug of choice is metronidazole. Pregnant females में you can use metronidazole or you can use clindamycin. Right? Now, in case your question is saying that there is profuse frothy discharge, ये word frothy होगा, right? And yellowish green in color, there is pruritus, itching present है, and strawberry cervix या strawberry vagina. This is how strawberry like cervix or strawberry like vagina is present, right? So this is strawberry cervix or strawberry vagina. This means they are talking about trichomonas. Pruritus है, frothy discharge है, yellowish green in color है. Strawberry cervix या strawberry vagina means trichomonas. Again, the drug of choice is metronidazole. This is an STD and that is why partner treatment should be done. Partner treatment should be done, right? And if they are talking about, and this is called spike trichomonas, all of you know, which is a motile flagellated protozoa, right? ठीक है. Now comes candida. Dose कभी भी नहीं पूछेंगे. Then comes candida. Candida के patient ना discharge से ज़्यादा उनको problem होती है pruritus. So the main problem is pruritus and they will have a curdy white discharge या cottage cheese like discharge. ड्रग ऑफ चॉइस इज फ्लूकोनाजोल. कैंडिडा में जो pH ऑफ द डिस्चार्ज होता है दैट इज लेस देन 4.5, राइट? So drug of choice is fluconazole. Now in pregnant females, the drug of choice is topical imidazoles. So यहाँ पे oral fluconazole था. It is topical imidazole like clotrimazole. Clotrimazole, right? Clear to all of you? Now these days we are going for syndromic management. Syndromic management of vaginal discharge में green kit is used, that is kit number 2, and this kit number 2 will have fluconazole, and instead of having metronidazole it has secnidazole. That is one thing which you have to remember. Ideally हम metronidazole use करते हैं, लेकिन in kits में it is secnidazole, right? And for vaginal discharge partner treatment is not done. अब अगर आपका क्वेश्चन कहे कि पर स्पेकुलम एग्जामिनेशन किया एंड देयर वाज अ सर्वाइकल इरोजन या सर्वाइकल अल्सर प्रेजेंट था, तो पेशेंट डिस्चार्ज के साथ आई एंड व्हेन अ पर स्पेकुलम एग्जामिनेशन वाज डन यू कैन सी अ सर्वाइकल इरोजन और सर्वाइकल अल्सर. Then instead of saying that I am going to treat her with kit number 2 for vaginal discharge, you are going to say that I am going to treat her with kit number 1 for cervical discharge. This is a question which was asked in NEET 2023 and many people got this question wrong. Patient has come to you with discharge and on per speculum examination, if cervical erosion or cervical ulcer is present, then please don't say that I am going to use the kit for vaginal discharge. Then you are going to use the kit for cervical discharge which has got tablet cefixime and tablet azithromycin, right? Now, if your patient comes with complaint of lower abdomen pain with any one of the following, uterine tenderness, adnexal tenderness or cervical movement tenderness, cervix को touch करते ही pain होता है, right? That means it is a case of PID and PID में जो kit use होती है that is kit number 6, that is the yellow kit. PID के patients में partner treatment करते हैं and for partner treatment you are going to use grey kit. Clear? So grey kit का use is one for cervical discharge and number 2 grey kit is also used for partner treatment if your patient has PID. In your patient you are going to use kit number 6 but for partner treatment you are going to use the grey kit, that is kit number 1, right? Now identify this instrument. All of you know that this is a Cusco's speculum, right? Now, what is the probable diagnosis from the image? The probable diagnosis, now first tell me, either it can be uterine inversion, yeah, it can be prolapse. Now, how am I going to identify कि ये inversion है कि prolapse है? Simple. अगर आपको os दिख रहा है, if os is visible, if os is seen, it means it is a case of prolapse. If os is not seen, that means it is a case of inversion. केवल यूट्रस दिख रहा है, os नहीं दिख रहा है. So यूट्रस दिख रहा है plus os is दिख रहा है, that means prolapse. Uterus seen but os not seen, this is os, that means inversion. यहाँ पे I can see the os, that means it is a case of prolapse, right? Do not say it is a case of inversion. In inversion, you will never see the os. In inversion, only uterus will be seen, but os will not be seen. Now, in case of prolapse, what is the risk factor? What is the most important risk factor? Birth trauma. Birth trauma is a very important risk factor and menopause. Birth trauma and menopause, most important being birth trauma, right? Now, how do you manage a prolapse? That depends upon कि कैसी patient आ रही है. If a patient comes with prolapse and she wants future childbearing, so in that case, I will go for sling surgery. I will go for a sling surgery. Please explain GT-PAL in short. But a GT-PAL I have explained in the OBS videos. Chalo, I'll explain to you. Towards the end, I will explain. Right? So stay till the end. If I get time, definitely I will explain. And if you people are, wanting to stay here for long, because it is already 12:30. Right. So if there is a female who wants future childbearing and she has a 3rd degree prolapse, I will go for sling surgery. If female is more than 40 years, she doesn't want any future childbearing and she has 3rd degree prolapse. Now I will do Fothergill surgery. Fothergill surgery. So if female wants childbearing, sling surgery. If female is more than 40 years, abhi menopausal nahi hui hai, right? And she says, I don't want further childbearing, so you will go for Fothergill surgery. Now, if female is menopausal and she doesn't have any medical problems, and she has a 3rd degree prolapse. 3rd degree prolapse. Then the answer is vaginal hysterectomy. Vaginal hysterectomy. So in a menopausal female, if she doesn't have any medical problems, I can easily go for vaginal hysterectomy, right? If she is a menopausal female who has come to you with prolapse and she has medical problems, in that case, you will say, I will do Lefort colpoclysis. Lefort colpoclysis. Now, if your question says that menopausal female hai and more than 65 hai, more than 65 hai, to no surgery, then ring pessary. Ring pessary. Right? So, depending upon what your question is saying, you are going to manage it this way. Menopausal female with medical problems and she has to be less than 65 years, go for Lefort's colpoclysis. Menopausal female more than 65 years, Lefort's bhi nahi karenge, I will go for ring pessary. Menopausal female hai, koi medical problem nahi hai, right? I will go for vaginal hysterectomy. Clear to all of you? Yes? Okay. Now, condition and named surgeries. This list you are going to make with me and we are going to complete this list quickly. Cystocele and urethrocoele की surgery को क्या कहते हैं? This is surgery for cystocele and urethrocoele is called as anterior colporrhaphy. What is the surgery for rectocele called as? It is called as posterior colpoperineorrhaphy. Right? What are you asking? What is the difference between colposcopy and colpoclysis? Beta, colposcopy is a diagnostic procedure. Colpoclysis is a therapeutic procedure which is used in prolapse. Right? Enterocele की surgery is McCall-Culdoplasty. McCall-Culdoplasty. Culdoplasty, I am writing it properly so that you don't make any mistake. Culdoplasty. Vault prolapse. Vault prolapse क्या होता है? Vault prolapse is prolapse of vagina after hysterectomy. And what is the surgery for vault prolapse? That is uterosacral suspension. SUI, stress urinary incontinence. Stress urinary incontinence. SUI क्या होता है? If a female has involuntary passage of urine on laughing, on sneezing, on coughing. So a female has involuntary passage of urine on laughing, sneezing, coughing. That is what is SUI. SUI की best surgery for SUI is Burch-Colpo suspension. Most commonly done is TOT followed by TVT. Right? Okay. सेप्टेट यूट्रस की सर्जरी को क्या कहते हैं? सेप्टेट यूट्रस सर्जरी फॉर सेप्टेट यूट्रस. What surgery do you do for septate uterus? The surgery which you are going to do for septate uterus is hysteroscopic. So with hysteroscopy you are going to do you are going to cut the septa, right? Hysteroscopic resection of septa. बायकॉर्नुएट यूट्रस की सर्जरी को क्या कहते हैं? स्ट्रॉसमैन मेट्रोप्लास्टी. CIN1 में क्या करते हैं? CIN1 में यू फॉलो अप फॉर 2 years. If it persists, then you go for cryoablation. CIN2 and CIN3 में क्या करते हैं? LEEP या LLETZ. कैंसर सर्विक्स का मैनेजमेंट. कैंसर सर्विक्स में अप टिल स्टेज 2A1 मोस्टली आप हिस्टेरेक्टमी करते हो, राइट? मोस्टली आप हिस्टेरेक्टमी करोगे प्लस लिम्फ नोड डायसेक्शन करोगे. सो अप टिल स्टेज CIN का मतलब सर्वाइकल इंट्राएपिथेलियल नियोप्लेजिया. CIN I have taught in cancer cervix. I have taken a lecture. I have taught there. So please remember, this is cervical intraepithelial lesion. This is a pre-malignant lesion for cancer cervix, right? LEEP या LLETZ का मतलब क्या होता है? Large loop excision of transformation zone. CIN2 and CIN3 में never are you going to say कि हम hysterectomy करेंगे. हमेशा CIN2 and CIN3 the management is LEEP or LLETZ. Never hysterectomy. चाहे क्वेश्चन कितना मर्जी कंफ्यूज करने की कोशिश करे कि फीमेल 60 years की है, 65 years की है, 50 years की है, never are you going to say I'm going to do hysterectomy, right? अब जो hysterectomy करते हैं यहाँ पे for cancer cervix, so ये यहाँ पे खत्म था. For cancer cervix up till stage 2A1 आप hysterectomy करोगे. This can be type 2 या type 3. Type 2 hysterectomy या type 3 hysterectomy plus lymph node dissection. लेकिन क्वेश्चन इस पे नहीं आएगा. क्वेश्चन आएगा कि अगर कैंसर सर्विक्स हो गया है in stage 1A1 in a young female. So if cancer cervix is happening in a young female and the stage is 1A1, what is the management? Management is conization. Conization, right? Cone shaped में cervix को cut कर देते हैं. Conization. From stage 2A2 to stage 4, management is chemoradiation. अगर कीमो रेडिएशन ऑप्शन में नहीं दिया होगा तो आप कीमोथेरेपी मार्क करोगे, सॉरी रेडियोथेरेपी मार्क करोगे. डू नॉट से कीमोथेरेपी, नॉट कीमोथेरेपी. Always you have to mark the answer as radiotherapy. Best answer is chemoradiation, right? And if chemo radiation is not given, then chemotherapy should not be marked. Then you have to mark the answer as radiotherapy. Who is spamming this and my attention is getting diverted? Okay. Now, chemo radiation और radiotherapy में क्या difference है? Chemo radiation का मतलब है that before giving radiotherapy, you will give cisplatin, which is a radio sensitizer, right? So cisplatin क्या करेगा? It is going to increase the sensitivity of the cells towards radiotherapy. That is why we say chemo radiation is the best answer, and if chemo radiation is not given, radiotherapy. Never say chemotherapy, right? Have you understood? Okay. Identify this instrument. This is a curette, right? So it is a blunt and a sharp curette. Okay. Then what is this instrument? This instrument is a uterine sound. Please remember, a uterine sound and a bladder sound should always be differentiated. Bladder sound में एक knob होता है, right? And bladder sound is calibrated, right? So that is a bladder sound. This over here is uterine sound. Uterine sound say you can measure the length of the uterus, right? So हम uterine sound को कब use करेंगे? जब हम dilatation and curettage करने लगेंगे, उससे पहले I'll use a uterine sound. When I have to remove IUCD, I can use a uterine sound. For suction evacuation, I can use a uterine sound. Endometrial biopsy is an OPD procedure. Right? And isme you don't need to go for uterine sound. Clear? Okay. Then, few important points about HPV. In HPV, please remember, the low risk subtypes are HPV 6 and 11 and they lead to genital warts. They lead to genital warts. High risk subtypes, you have to remember these because they are all used for Gardasil 9. Right? So Gardasil 9 protects against all these. That is why you have to use them. 16, 18, 31, 33, 45, 52, 58. You have to remember these high risk subtypes. Now HPV can lead to cancers. Females may it can lead to high risk subtypes can lead to cancer cervix, cancer vulva, cancer vagina. In males, high risk subtypes can lead to anus cancer, penis cancer, right, and oral cancers, right? Now, low risk subtypes are 6 and 11 which lead only to genital warts. HPV vaccines में you have to remember कि Gardasil को याद रखो. Gardasil is a quadrivalent vaccine which protects against HPV 6, 11, 16 and 18. Then Gardasil 9 को याद रखो, which is a nonavalent vaccine which is protecting against 9 strains. All these 9 strains you should remember. You also have to remember कि अभी India has launched its first cancer cervix vaccine which is Sarvavac. Sarvavac is again a quadrivalent vaccine which is protecting against 6, 11, 16 and 18 and it is prepared by Serum Institute of India, Pune, right? Then all these vaccines are prepared from L1 capsid protein. Age group for giving HPV vaccine is 9 to 26 years. In high risk females, you can give it between 27 to 45 years. Ideal age is 11 to 12 years. WHO SAGE recommendation. WHO SAGE recommendations पे question आता है. Now it is said that WHO कहता है between 9 to 20 years. You have to give 1 or 2 doses. Right? More than equal to 20 years, 21 years पे 2 doses. So 9 to 20 years तक 1 or 2. More than equal to 21 पे 2 doses. HIV positive में 3 doses. Very simple. 9 to 20 years में 1 or 2. Right? then more than equal to 21 पे 2, and then HIV positive है, then 3 doses, right? There is no need for doing HPV DNA testing before giving the vaccine. Vaccine can be given to sexually active females also. It is contraindicated in pregnancy. Most common side effect is syncope. And after vaccination, do not stop screening. Everything about cancer cervix screening I have told you in the Chota Packet video, right? So go and watch that. Now, this swelling whenever it comes to you, this image whenever it comes to you, it is a Bartholin cyst, right? So whenever you get this swelling, it is a Bartholin cyst, right? What is the management of Bartholin cyst? Please, answer change हुआ है. Management for Bartholin cyst is incision and drainage. अगर question आएगा recurrent cyst, incision and drainage. अगर question आता है management of recurrent Bartholin cyst, the word recurrent should be there. Then you are going to say marsupilization. Then it is marsupilization, right? So whenever this image comes, it's a Bartholin cyst. Management of Bartholin cyst is incision and drainage. Management of recurrent Bartholin cyst is marsupilization. We have done all this. Precocious puberty. Now I'm going to end the session because everything after this is something which you have to read. You have to go through this table of emergency contraception. Please remember कि इंडिया में वी आर गिविंग, जो गवर्नमेंट ऑफ इंडिया मोस्ट कॉमनली दे रहा है, दैट इज 1.5 mg सिंगल डोज ऑफ लीवोनॉर्जेस्ट्रल. दैट इज द मोस्ट कॉमन इमरजेंसी कॉन्ट्रासेप्शन विच इज बीइंग यूज्ड. Emergency contraception means that you are using it after unprotected intercourse. You have to use it after unprotected intercourse, right? Best time is you give it within 72 hours. But maximum you can use it up till 5 days. Right? Maximum it can be used up till 5 days. Right? But मान लो एक पेशेंट हमारे, एक फीमेल आती है who is a case of rape and she comes to you on 5th day. On 5th day अगर आ रही है, so in that case, see, पहले तो any female who's coming to you on 5th day, the best thing is copper IUCD. Most effective method is copper IUCD, right? सबसे ज़्यादा effective जो होता है that is copper IUCD, and copper IUCD can be used within 5 days after unprotected intercourse. But then it is not suitable for rape victims because infection and tears वगैरह होंगे, right? तो 5 days पे रेप विक्टिम अगर आ रही है, then what should I do? Because levonorgestrel जो है, this is best only up till 72 hours. Most commonly used होता है and it is used only up till 72 hours, right? Copper IUCD can be used on 5th day, लेकिन copper IUCD is not very good for rape victims. So in that case, you are going to use ulipristal. Ulipristal can be used till 5 days. You can use ulipristal till 5 days, right? Now, एक बहुत बड़ा confusion जो आप लोगों को होता है, that is कि levonorgestrel, because it is an emergency contraception, this means progesterone only pill is also an emergency contraception. No. Progesterone only pills are not emergency contraceptives. Progesterone only pill, levonorgestrel is an emergency contraception. Progesterone only pills are not emergency contraceptives. Progesterone only pill जो इंडिया में available है, it has desogestrel, and desogestrel is not an emergency contraceptive, right? Similarly, copper IUCD is an emergency contraceptive. Mirena is not an emergency contraceptive. Misoprostol is not an emergency contraceptive. Mifepristone is an emergency contraceptive. So please remember, most commonly used emergency contraceptive is levonorgestrel. Most effective is copper. Most effective hormonal is ulipristal. Copper IUCD and ulipristal, both of them can be used up till 5 days. Copper IUCD, although it is the best one, it is not very good for a rape victim. So if a rape victim is coming on day 5, I would prefer ulipristal. If ulipristal is not given in the options, then okay, go for copper IUCD. But if ulipristal is given in the options, then I am going to go for ulipristal, right? इसके अलावा माला डी या OCPs are also used as emergency contraceptive. Centroman is used as emergency contraceptive, and mifepristone is used as emergency contraceptive. Emergency contraceptives, they should be used ideally within 72 hours of unprotected intercourse, but they can be used up till 5 days, right? Then I want you to remember absolute contraindications of OCPs. The mnemonic is banks have various schemes to provide home loans during May. Just go through it. These are absolute contraindications of OCPs which should be on your fingertips. Then absolute contraindications of IUCD. अगर ये PSM में कुछ different पढ़ाया, although if you are a student of Marrow, Dr. Mohit has taught you these absolute contraindications only. But if you are not a subscriber of Marrow and you have studied from elsewhere, I want you to remember these. Not because I am telling you, because these are the most updated ones, right? So this is what I wanted to revise with you before your FMG exam. Please remember that till now what you have done, you just have to revise that much. Keep on revising what you have done. Give focus, lay more stress on PYQs. And जब PYQ कर रहे हो, don't just do the PYQ, do the previous year topic as well. Do that particular topic and I'm sure all of you will sail through. You have to get 150 marks and there is no negative marking, right? So why are you taking that stress? You shouldn't be stressed at all because हमें 150 ही तो लाना है, right? And the only thing is that you have to practice MCQs. What happens is that so many times you are going to miss out the word except, you are going to miss out the word not, right? So many times you miss out on those words. So that is something which you don't have to do. As of now, you have 13 days to go from now. In these 13 days, you are going to revise all the PYQs. ये जितने भी सेशंस आपको important sessions हैं, whether it is an important session in Obs Gyne, whether it is a last minute important session which any other teacher has taken, and if you've attended those sessions, उनके notes को बस revise करते जाओ, because at the last, what the teachers are doing, how do I prepare a session for you? I take up all the previous year questions and then I try to cover those questions in a little detailed manner, right? So that केवल वो question cover ना हो, so that the previous year topic is also covered. Now, Saurabh, you are asking me about the 6.5 edition revision notes. Now, if you've done edition 6 revision notes and you have to appear for FMG just now, you shouldn't be going through edition 6.5 revision videos. अगर edition 6 कर लिया है, that is more than enough. If you are a Marrow subscriber and अभी तक edition 6 के revision videos नहीं करे हैं, then you can choose either you can do edition 6 revision videos or 6.5 revision videos. Both of them are good for you, right? You should be doing that. If you are not a Marrow subscriber, in that case, if you want to revise OBGY, Gyne, I have revised with you today, and Obs is there on the Telegram channel. On Telegram channel, the class which I had taken for Alan, the entire material I have put it on my Telegram channel, right? So you can go through those notes, you will understand everything. Anything else? Marrow, my eyesight. Diagnosis of atypical uterine bleeding, beta nothing you have to remember. Atypical uterine bleeding, abhi jo maine bataya, atypical uterine bleeding mein, if your patient is having bleeding and she is coming to you with tender uterus and dysmenorrhea, it means it is adenomyosis. If she is coming to you with atypical uterine bleeding and this bleeding is irregular, right? Or intermenstrual bleeding, it is a polyp. If she is having atypical uterine bleeding and the uterus is enlarged, it is irregularly enlarged, 20 weeks pregnant uterus size, it is a fibroid. Staging कैसे याद करें? Staging, I don't want you to remember every staging. I just want कि जितने भी gyne cancers हैं, whether it is endometrial cancer, whether it is cancer cervix, or whether it is ovarian cancer, just remember stage 3. I want you to remember only stage 3. Stage 3 सबकी पढ़ लो. अगर क्वेश्चन आएगा तो स्टेज 3 से आएगा, अदरवाइज नहीं आएगा, राइट? GT PAL, ओके. सो GT PAL, so whenever gravida is represented by a single number and parity is represented by 4 numbers, that means they are following the GT PAL system. Gravida means present plus past conception. That means how many times a female has conceived, including this time, right? So gravida में present pregnancy को भी include करते हैं, and how many times in the past she has conceived, right? Parity में जो first number लिखा होगा GT PAL system में, that is number of previous term pregnancies. When do you say it's a term pregnancy? Term pregnancy का मतलब है any delivery which is happening after 37 weeks. B stands the second number, that is B. This second number B is going to stand for number of previous preterm deliveries. And from where do you count preterm deliveries? Preterm deliveries should always be counted from 20 weeks to 36 weeks plus 6 days. Then C stands for number of abortions. That is any pregnancy which ends at less than 20 weeks. So any pregnancy which is ending at less than 20 weeks, it could be ectopic, it could be molar. And D stands for number of living children. So please remember GT PAL में, in GT PAL, this P is number of preterm. It is not parity. एक तो ये चीज ध्यान रखना, right? And जब आप living children की बात करते हो, in living children, twins will be taken as 2, triplets will be taken as 3. राइट? नॉर्मली हम ट्विंस को सिंगल कंसेप्शन मानते हैं, ट्रिपलेट्स को सिंगल कंसेप्शन मानते हैं, बट वेन एवर वी आर टॉकिंग अबाउट द नंबर ऑफ लिविंग चिल्ड्रन, ट्विंस विल बी काउंटेड एज 2 and triplets will be counted as 3. ECT can be given in pregnancy. Saurabh, ECT normally we don't give in pregnancy, right? So ECT should not be given in pregnancy normally, unless and until it's a very, very severe condition. Till that time you don't give ECT in pregnancy. Clear? My Telegram channel, I told you, I have written it here because YouTube, Telegram and everything gets mixed up. It is in capital letters. You have to search for OBG by Sakshi Arora Hans, and there are various Telegram channels which are opened by my name. So in my case, follow that channel where there are around 34,000 subscribers. So if there are 34,000 subscribers, that is my original Telegram handle. Now just a small quote which I liked so much and I thought I'll share with you all. And before that I just want all of you to subscribe to my YouTube channel, right? So subscribe to the YouTube channel so that next time if I am taking a class, I'm not promising, but if I get time, I will take a class on important images, but this is not a promise, right? But yes, please subscribe to the YouTube channel. And this was a very nice quote which I found. मंजिलें उन्हें नहीं मिलती जिनके ख्वाब बड़े होते हैं, बल्कि मंजिलें उन्हें मिलती हैं जो जिद पर अड़े होते हैं. So all of you just have to have that confidence and you have to say to yourself that I am going to clear this exam. I am not going to quit at this moment, right? So all the best to all of you, and I'm sure all of you are going to do really very well. If you have any queries, you can ask me on my Telegram handle. You can also follow me on my Instagram handle for any update which is there. The PDF, I'm going to share it in the group just now. Immediately after the class, I'll share the PDF with all of you. Right? So, love you all and all the best to all of you. Don't forget to subscribe the channel. And if you have liked this video, share it with your friends also, so that they can also get benefit from this last minute revision in Gyne. Right? Yes, you will pass, and I'm sure all of you are going to pass. Take care, love you all, and I'm going to see you on the other side for NEET PG when you are going to attend either my live class or you will be a Marrow subscriber for NEET.